But before that, I would like to discuss something which is really important. Look, you all know My Rehab Academy needs no introduction when it comes to teaching and education for our fraternity of physiotherapy. We have successfully conducted more than 3,000 hours of digital teachings till now. And the best part is 80% of these are free. On your great demand, we are bringing the important courses like dry needling and chiropractic, manual therapy, everything in coming month. As you all know, dry needling dates have been announced and registrations have been opened. So who all wants to register, especially those who are the budding practitioners or students of masters or final year bachelor, everyone can contact me or the 24/7 number. We have learn now, pay later type of program where actually we help students to go ahead in that way. We have very easy kind of payment system. So the dry needling is by Sir Craig Smith. He is one of the renowned dry needling instructor in the world, and he has been associated with Indian and South African cricket team as well. Across the world, his fame in teaching is actually something which needs no introduction. All of you are informed that we have many free courses coming up. For that, you don't need to do anything except taking the membership, which is at hardly a movie ticket cost. So you all can enroll for the membership, whoever is not still enrolled, and can get benefit of joining many free courses, getting discount in many of our physical events, and the best part is like you can browse through our e-library, which is the largest, one of the largest collections we believe in the fraternity of physiotherapy, where you can have access to many other journals, books, and the write-ups. So coming to today's event by Dr. Pallavi Singh, I think she has joined. Okay, it's about the foot evaluation in OPD on daily basis. When it comes to foot, it is one of the most important part. And I have seen people having a lot more confusion when they start evaluation. We will have today's event, and after the event, we will announce even the physical event also. Maybe the dates will be announced in few days, but and the location as well. And the foot evaluation, when you learn theoretically, it will be very easy for you to learn practically. But today's is the introductory class for that. So hope you all will enjoy, and you will be able to ask the questions. You can go through our guidelines. You all have to join through video. I'm very strict in this manner. If video is not on, our tech team is monitoring very well. I can tell you they can remove any one of them. So kindly switch on through the video. We all want to know your interaction, and don't ask questions in between. Please ask question when ma'am give your time, because madam will be giving you, that breaks anyone's rhythm, anyone's flow. So kindly ask your questions in the break, in the time given by ma'am. And moreover that, if you have any questions, many of you ask personally to my WhatsApp. So I would request that you can put it in chat box, no problem. Or you can put it in your group as well. So if it is possible. So, we can ask your questions to ma'am, and then wait for your questions, because many a times when you ask your question is already answered as it is asked by someone else. So please be patient, join through video. And I would request that if this event is, I don't know, maybe for our members on YouTube premium quality, it is being live there also for our premium members. Anyway, you all can join our YouTube also. YouTube channel, everything will be given at last. You can join and you can see there are many other videos, very effective and very learn worthy. So kindly go through all these things. See you, sir.
Please.
Yeah, if ma'am is ready now, part is
ready. I just need access to share the screen, or you make me the co-host if possible.
Ma'am, you are already closed. You can just try now.
Please try once again. You are already co-host.
Give me some time. I don't know why the desktop is not coming.
The screen share screen button is showing, man.
The share screen button is coming, but the file is not opening. Yeah. Just a second.
Yeah, we can see now.
Please let me know if you are just seeing one screen or multiple screen.
It's multiple. You could reduce that.
It's fine now.
Yeah, fine. Come.
So good morning all. This is the very start of any online class or session. Some technical glitches, some here and there. So now we are on board. Let me first try and introduce myself. Thank you, Dr. Saurabh and the whole team of My Rehab Academy for organizing this workshop. I'm Dr. Pallavi Singh. I'm majorly practicing in Mumbai. I have done my physiotherapy in 2006 from Indore. Then I was part of fitness industry as the gym manager for Golds and Talwalkar's gym chain of fitness center. Uh, then I moved to Mumbai, and from 2010, I'm probably the first physiotherapist who has gone into podiatry and try to learn it. So over the period, I have integrated the knowledge of my physiotherapy, my fitness knowledge and expertise, and the knowledge of podiatry. And together, I have come up with a better solution for people who are suffering with mobility related problem. My company name is Stride Fitness and Mobility Clinic. The brand name is Stride Podiatry. We have 3 clinics in Mumbai, Indore, and Jammu. I have a lot of associate. I have trained more than 500 doctors in podiatry, and mostly my passion lies with the feet. There is a lot to do, and there is a lot of false knowledge that is being floated in the market in terms of the solution for various common problems like plantar fasciitis, heel pain, the flat foot kind of a problem. So there is a lot of myth. Today, we are trying to cover a few topics in this 3 hours of timing. And I hope I will be able to give you some insight to why podiatry is important in your day-to-day practice. And if you use a little of what you learned today, you can see a lot of better result coming for your patients in future. So let's not waste time because it's a Sunday morning and you have already taken out time. Very first thing that we see in body or foot, we start with anatomy, the most boring part when you are there in the schools, but I'll try to pass through it as interestingly possible and as fast as possible. So why we need to study the feet as such? It's one of the most important part in our body. And I do remember when I was studying, we hardly had one lecture on feet, and there was no question in the exam based on foot. So foot biomechanics is something that people choose not to even study when they are preparing for their exam. And last 15 to 20 years, what I have seen, the incidence of foot related problem has increased, and there is a huge shift of people wanting to know or learning to know about feet and the correlation with other joint. So very importantly, 25% of your bones in the body are there in the feet. It's the most strongest part if it comes together, though the bone structure is very small, but when they come together with the help of the numerous ligaments and tendon, they can take as much as 4 to 5 times of your body weight. At a walking cycle, when you are in a toe off phase, you take almost 8 times of your body weight on one small joint. That is the first rate. Very importantly, whenever you are examining the foot, whenever you are studying the foot, keep on remembering that it's a 3-dimensional structure, not a 2D structure, though it's majorly coming into the hinge joint category in people's mind, but it is not a hinge joint, and it is usually in 3 dimensions. So understanding the 3 dimension of the foot is the most important thing if you can do today. Between the male and the female, if you see, there is a lot of problem in the female body in the feet as compared to the male. There are various contributing factor to it, but structurally the number of bone and the structure of bone is same. But the way the pelvis of the female is, the dynamics on the foot changes because of that. So do consider people who are having a back related problem, chronic back pains, heel pain together, then both the joints are working in conjunction or against each other to cause this kind of a pain. If we talk about the foot structure, we have 26 bones in it. If you include 2 sesamoid, then it is 28. Between these 28 bone, they form 33 joints. And each and every joint is not like a fixed joint. They do a lot of mobility also. So there is minor or major movement at almost all the joint. Now these joint, because it's a weight bearing joint and your whole body weight is supported on it, along with that the foot is adapting to different surfaces like sand, like rock, like flat surface. You can jog, you can run, you can walk. So all those things can happen only with the interchanging role of the foot in terms of the ligament locking and unlocking mechanism. It's very important the way foot decide to make itself a rigid lever at one point, and at the same time it is a flexible part of the foot as well. Just for the understanding of the feet and to make things simple, we have divided feet into 3 parts: hind foot, midfoot and forefoot. So if we go with the structure of the hind foot, majorly what we are seeing is the talus and the calcaneum. When we are talking about the midfoot, it is the cuneiform bones, cuboid and navicular bone. And when we go to the forefoot area, we have the phalanges and the metatarsals. Most of you are aware about the basic anatomy and how the foot look like. Just have this image in your mind when we are further going towards it. When we are talking about the function, as I told, it helps us in supporting our body weight. It gives us the flexibility. It gives us the shock absorption. Shock absorption to me is the most important part. If your foot is not a good shock absorber, you will have knee arthritis for sure. I can give you a certificate that if you are not having a good shock absorption at feet, you will definitely have knee arthritic cases in the patient for sure. And if they don't take care of the footwear type, then they will have chronic back pain associated with this kind of foot type. It sometimes helps in compensating if somebody is having difficulty with the hand amputation and this thing, then feet can in certain people they have adopted to do paintings through feet. So you can understand that though we don't use our feet as flexible and as expanded as the hands and the fingers, but our toes can also have that much mobility. So we restrict our mobility in the feet with the help of shoes, tight shoes, ill-fitting shoes. But if we let them go free and do a lot of functional training, we can use our feet equivalent to our fingers in the hand. So do remember that particular part of mobility when you are trying to do exercise training to your patient with foot related problem. This is a top view of the feet, how it looks like. If you see, there are so many rims and surfaces where the joints are coming together. There's a lot of cartilage between these surfaces all over the toes and towards the heel as well. These cartilage are the one who once get eroded or decreased or thin, started giving you the effect of arthritis, or you have some unidentified pain also. People who have a lot of flat foot, you will see this naviculum bone dropping down. It is touching the ground to the level. Usually it is shifted up, but in flat footed cases, for all your walking posture, And now when I'm talking about walking, imagine you walk about 8,000 steps a day. A human in his life can walk throughout the globe for 4 times. So that much walking you do in your lifetime. Uh, that much walking has to be done by the complex system of the foot support that we have. We'll study more about it, but just try to remember this picture. The calcaneum is the most posterior and the bigger bone. Then just next to it is navicular. Opposite to navicular is cuboid. Navicular and cuboid are the major pain causing bone in any of the foot related problem that you will see on a regular basis. Cuboid syndrome is way too common in high arch people, and navicular drop and navicular pain is way too common in people with flat foot or low arches. So you will see the pain which is just at the end of the heel but not in the plantar fascia zone. What happen is most of the time people wrongfully notice that the pain is plantar fasciitis or calcaneum spur, but it could be navicular drop and drift that is causing them the trouble. That is more troublesome than these kind of soft tissue pain like what you get in plantar fasciitis or Achilles tendonitis. And people keep on giving soft sleepers or gel cushions or inserts that they assume will solve the heel pain. It cannot solve the heel pain if you cannot reposition the navicular back into its original zone. So they need to be in their particular position to perform well. If they are, because of over flexibility or under flexibility, leaving their bone positioning, they will have a lot of strain on them when we are standing, walking and moving around. I hope this point is clear to you. This is what practically important. This is how the complex system of tendons and ligament looks like. Most importantly, you will see ligament tears in the ankle, which is lateral collateral ligament. That is the most important one. But as a regular examiner, you should try to palpate the arteries in the feet. You should try to see the flexibility of the ligaments and tendon, not only at the ankle level but at the great toe level also, because these are all interconnected. You can see the fascia around here. All the muscles are attached to the fascia. So if the fascias are not that eased off, the muscles will start pulling much faster and you will have a lot of injury. Now imagine if you are driving a scooter or a car, whatever you use for transportation, and you don't take it for servicing ever, what will happen? The very first thing that will happen is you will lose the shock absorber. You will have a very bumpy ride when you're trying to drive those kind of cars. When you're not putting proper air pressure in the tire, it cannot give you the shock absorption. The foot in our body is a shock absorber, so our feet is more and less similar to a car tire whenever you are looking into the walking and the mobility aspect of the feet. As I told you earlier, it looks like a hinge joint, but in all reason, it is not a proper hinge joint. It's a very complex joint. Actually, it is a combination of 3 joints to form a ankle joint. We don't call it as a joint. We mostly call it as a ankle complex rather than calling it as a joint. So don't see one joint. You will always assume the subtalar joint as the anchor joint. But we have 2 more joints, that is distal tibiofibular joint and talocrural joint. So this 2 along with the subtalar joint makes the ankle complex. Most of the examiner are hellbent and concentrated over the subtalar joint. If they see subtalar is inwardly rotated, then they will say, oh, you have a flat foot, and that is how they start their treatment. And if it is supinated, they will say that you have high arches and you have to do this for this thing, and they forget to see what is the position of all other jointed. The talocrural joint is hard to see. Even on the x-rays, not many doctors notice that thing because of the fact that it is a mortise, not even a joint. So जब हम लोग carpentry करते हैं, the logs of wood to form a table is being attached in a picture that I have shown you like right now. This is called as the mortise. The joint, the way the bone goes inside another part is called as the mortise, and the talocrural joint is very similar to this thing, and it is being held together with the tendons. So this is how you can see the picture of your joints. Very first, the green one is the tibiofibular joint. That is where the top of the shelf come. These two bone, sometime it is malposition, and they have eroded cartilage. If you see regularly, the distance is not too much between them. But while walking and running, if this area had some kind of post injury, like some ankle sprain has happened, or something like a fall or something, you will see a lot of swelling around the malleolar area, and underneath this area will be inflammation, or there can be a little thinning of the cartilage happening, or arthritic changes happening. If thinning happen, then the bone will come more together and start eroding each other, so you'll have arthritic changes in the distal tibiofibular joint as well. Then come the talocrural joint. On the top there is fibula and the talus, and on the bottom it's the head of the calcaneum, so it forms the talocrural joint. Now again, if you see, it's a very uh, broad joint in terms of the surface, and the reason is, it while providing the support from the upper body, it gives a good access for the bone to cross against each other. So it's more of a gliding that happens at this joint, rather than stability, or you can say mobility restriction kind of a thing. So this is the joint which help us to have full mobility at the ankle joint, and that's why they are taken more precedence when we are doing the examination of the feet. Then comes the subtalar joint. Now subtalar joint is the most important joint in this ankle complex. Correct me if I have wrongfully told you that this is calcaneum, because this is talus. Sorry, I think I have said it is calcaneum. So the joint is between tibia, fibula, and talus. The subcrural joint. The subtalar joint is between the talus and the calcaneum. And if you see the blue lining running around, this joint is something which gives you the eversion and eversion, and it helps us in doing the pronation and the supination of the feet as well. Now these movements are way too important. When you little bit understand the biomechanics of the foot, you'll understand the importance of these particular joint. The most important movement that the ankle joint we see is the dorsiflexion and the plantar flexion. We have various blood supply, anterior tibial, posterior tibial, and fibular arteries are the one which are supplying. And if you see on the neural side, tibial and the sural nerves are supplying over there. Peroneal is the most important nerve. If you see any kind of impingement, mostly in the diabetic people, you'll have a lot of pain, discomfort, and lack of control over the ankle joint. Ligaments, you know, most of them, talofibular, posterior and anterior, then calcaneofibular, deltoid hai, tibionavicular hai, fibular. Collateral ligaments are the most important. Medial and the lateral collateral ligament, they are the most important ligament that you will see for stability and mobility. Most of the athlete who don't have good conditioning about the feet, they have tightness at the calf muscle, will have more incidence of sprain and injuries. And mostly the football player, because they are playing on a ground where they are running in different direction, and they are wearing spikes. So sometimes what happen is the spike is stuck inside the surface of the field, or in the turf that they use for running and jogging. And once the spike is stuck and their movement is turned, they usually don't have a good adoption to the movement, and then their body gets sprained much quickly and faster. If we talk about the subtalar joint, the most important movement that the subtalar joint does is eversion and inversion. The posterior and the posterior tibial and the fibular arteries are the arteries that are supplying. Pronation is something which is a combination of three movement. So I'll try to explain you that particular part a little later. The most important joint to me, and there are midfoot joint I'm not covering today because it gets a little boring for you and little complex also. But what is more important for us to understand is the first ray. First ray is the toe that we are talking about, the great toe joint. It is between the first metatarsal and the first cuneiform bone. So it is not just the phalanges we are talking about from behind till up. It is the end dome of the arches that we are talking about. And when we are standing and walking in different cycle of gait, the heel works as the stabilizer. The midfoot work for the stability to transit the body, but the transition only happen at the first ray. That's why the first ray to me is one of the most important joint. And it is a little hard for me to explain you on online basis that how to examine the first ray, but we see two things in great toe, that is hallux limitus and hallux rigidus. So if you don't have a good flexibility or you have hypermobility at first ray, there are typical problem that you will experience. I'll cover those problem in the future slide. So let's come about the axis and plane. I know most of the people don't love the axis and plane and don't like to read much about it. But I would still insist, if you can take out some time and try to understand how the body works, best way is to understand the axis and the plane. So let me try to simplify things. Imagine a rectangular box. The boxes have surfaces. One is the horizontal, one is the transverse surface, and then there is the two end of the box as well. So we can see it from the front, we can see it from the side, and we can divide it from top to bottom. Now, why it is important? When we are moving, okay, we are moving against the forces of gravity. Whenever we are standing and walking, a lot of gravitational pull and forces are applied to our body. If you see the picture of the guy standing, it is standing in an anatomical position. So say when we are walking around, there are grids of gravity that is crossing our body, and then there are grids of gravity which is going upward, sideways, and dividing our body into different segment. So when a person is stand and the body we are looking in front of us is divided by these segment, we have to see what is the clear divide. So is the body divided half and half equally? In the clinical examination, how you see that if the shoulders are level or not, if the hip or the pelvis is leveled or not, if the ankle is leveled or not. If they are leveled, then the weight distribution will be as far as possible similar on both the side. Now in case of foot, if this weight bearing is not similar, say in a case of frozen shoulder, the body is tilted to one side, or the person is trying to lift the shoulder up and creating more load onto the other side, or in a case of scoliosis, the body is shifted to one side, so obviously the weight will be shifted to one side. In cases of LLD, when the leg length is not similar, the weight is shifted to one side. In all those conditions, the body weight is not increased by a kilo or something. It, as I said, that we take 3 to 4 times of our body weight in different movement. So the weight is increases by 30 to 40 kg when you are shifting 3 to 5 kg to one side. So it is very important that the weight distribution between the feet is equal on both the side. Then it comes between the hind foot and the forefoot area. Again, they are the two end of the arches and the ligaments. So the weight distribution, usually a accepted percentage is 60-40. The hind foot to midfoot takes about 60% and the forefoot takes the 40% of the weight. If it is equally divided also, it's fine. In cases of flat foot, the anterior percentage increases and the posterior decreases. In case of high arches, there is no midfoot support, so the heel and the forefoot pressure is higher in those individual. Now, wherever the pressure is higher, you will develop corn callus ulcers, or you can develop internal inflammation in terms of posterior heel pain, Achilles tendonitis, or you can have calcaneum spur kind of a issue. So weight distribution is henceforth most important when we are looking into the body. Then we are talking about the transfer plane. In transfer plane, we are mostly trying to see the pelvic tilt from the foot perspective. We need to see whether the pelvis is anteriorly rotated or posteriorly rotated. In case of flat-footed people where the pronation is happening, what we see is there is an anterior pelvic tilt and there is an increased lumbar lordosis. Now, when that is happening, the forefoot pressure under the toes will increase. And if the person of this kind is a diabetic person, a person with obesity, and a weak extensor muscle, will have increased chances of having forefoot ulceration and amputation. So in case of diabetic foot, we cannot take it easy and not do proper treatment. And what we are trying to do is we are giving them some soft chappals. We are trying to tell them that you go to Scholl's or Bata and other brands and buy something which is soft. Now imagine my body is about 80 to 90 kg and I'm wearing a soft chappal. What will happen? And my anterior pelvic tilt will let the foam in the front go softer and smaller much faster, and then my pressure on the toe will be much higher. So that's why wearing soft footwears for a person with this kind of a body type is not a good solution. So that's why we need to see the body from front, back, and sideways. As I told you that we have the triplanar motion at our feet. This is how the foot works. So in pronation, we have dorsiflexion, that is the first movement. So we dorsiflex, that is a movement in the sagittal plane. Then we do abduction, the foot goes slightly outward to allow our feet to walk forward. So when the heel strike the ground, the foot has to pronate. So pronation is a normal function of the foot. But if we do more than the required degree, then it is a medical problem that we call as overpronation. So second movement is abduction. The foot slightly go outward to allow the further progression on the talocrural joint to happen. Then what happens is our feet slightly go into eversion, and then the full locking of the leg happen and the body weight started shifting towards the front. The other leg started coming off the ground, and by that time this leg is into a stable position and ready to transport the weight of the contralateral leg from behind to ahead. And then once the other leg started taking support, at that point our foot goes into slight supination. It changes the position from pronation to resupination or supination. At that point, the feet slightly do plantar flexion, goes into little adduction and inversion, and then the foot leaves the ground. That is how we progress. Now, while doing the pronation to the supination angle, the first ray is the fulcrum on which the body rotates. So now imagine your body weight and that particular small joint that has provided us the mobility from one plane to the another plane, and then provide us a stability to be only on one feet because the other leg was in the swing phase. I hope this is not too complex and confusing. If there is a particular question or something, you let me know. Otherwise, I'll move ahead in this. I think there is a WhatsApp group also. So if you have access on it and you want to drop a question over there, if I miss something over here, you can drop the question over there as well. I will try to look into that and answer you back right now in the chat.
Participants can answer.
Yeah, if there is something, please put it on the chat, and I would request Dr. Saurabh, if some question pops up and I couldn't see you, just please let me know that there is a question at this hour.
Sure, ma'am.
Okay.
Last, at least
So
we'll put it on last, no problem.
okay.
Meanwhile,
I'm
I'm just
assuming. Yeah, I'm assuming that till so far everybody is clear about what we have covered. Now we try to see the feet from the medial side and see the medial longitudinal arch, how we are making the medial longitudinal arch. So the bones involved in the medial column is the talus, naviculum, cuneiform, metatarsal, and the calcaneum. This is the side view and this is the top view of the medial column. Now, why we are talking in terms of column is we are trying to understand the arches of the foot. So we have two or three arches of the foot. We know the medial and the lateral arches more prominently, but we don't know the transfer arch very commonly while we are studying the physiotherapy and biomechanics side of the things. The transfer arch is the one that is the front portion between the metatarsal bone, and that is where the support and stability and all the progression happen. And it is very difficult to see because medial arch is a big arch. It is more visible. You can see if it is going up and down. But it is very difficult to examine the transfer arch when you are not very tuned to do foot examination on a regular basis. So the lateral arches are on the other side of the feet, mostly from the calcaneum going towards the fifth toes. This is how the lateral column looks. Calcaneum, cuboid, the fourth and the fifth metatarsal becomes the lateral column of the arches. Column is a word that you will always see when we are talking about a bridge. Whenever we are trying to form a bridge, we have two columns on which we lay the road and make a bridge. The bridges, if you see on that small column, can take the load of trucks, cars, whatever traffic it is going. Even you can pass trains on a bridge. So the bridge is being the most stable part because of the dome and the structure that we create in that. So the foot has also been created that way. There is a dome in the between, and there are two columns at the hind foot and at the forefoot area. And there are, if you see the transverse and the longitudinal arch in the representation, transfer arch is the one which is connecting the medial and the lateral arches of the foot. So it's the interconnection over between. But mostly we can visualize that at the metatarsal bone area, where the blue arrow you can see, that is where we examine the transfer arch. But it is the arch or the dome, the crux of the dome all throughout. For a high arch person, this area, the mid area, if you can see the arrow over there, where the blue line is connecting, that is called as the instep of the foot. So in the instep area, all the cuboid bones are coming together, and if they are too rigid, you can see that particular bone is raised and this metatarsal area is too down. The physical examination, it will be more clear if you see those things. Along with the foot, the lateral column and the medial column and the arches of the foot, the three arches of the foot, what we try to do is to encompass a lot of ligaments and tendon. Now, these are the structural part of the thing. The functional part is the plantar fascia that helps in causing the stability and the mobility of the foot. To see the proper functioning of plantar fascia, the most easiest test is called as windlass mechanism. In windlass mechanism, you simply ask the person who is standing in front of you to stand bare feet, and while their great toe area, the first area is planted on the ground, they have to raise only the toes up. In the second picture, how the toes are being lifted up. So some part of the forefoot is onto the ground, the heel obviously is on the ground, and then you're lifting the toe up. So what you will see, the positioning of the arches as the plantar fascia get tight will go up. So if you're seeing a person who is flat footed, you can see there is no medial arch available, and you ask them to do this windlass mechanism technique. At that point, you can determine whether they have a flexible flat foot or they have a rigid flat foot. If they have a flexible flat foot, that is a hyperflexibility disorder. Mostly the congenital people who are born with a flat foot are hyperflexible, and that's why once they try to lift the toes up, the fascia gets shortened and tightened and their arches will lift up. People who have secondary flat foot or adult acquired flat foot that has developed during the course of life due to wear, tear, wrong footwear, injuries, body weight, lack of exercises, and some knee related problem, then their windlass mechanism is always poor. They cannot lift much or they cannot lift at all. So those kind of the people are less responsive to the orthotic therapy. So you, while you're treating them, you still use the orthotics and try to correct their arches as much as possible, but set the goal right, that you are trying to give them maximum comfort, not to try to treat their flat foot. Okay, their arches will always be flat as soon as they come out of the insoles and orthotic support that they are wearing. In flexible flat foot, if they work on their body structure, they do the toning of muscle, they do a lot of exercises and functional training, there is a minor chance that there will be some development of arch that can be seen. But in my career, I have typically not seen many people coming out of the flat foot completely. For kids, when we start at 7 years of age, I have seen people growing now, that old I am. So I have seen them having a little development of the arch by 18 and 19. But to be honest, don't promise somebody that I will make an insole and that will make your arches normal. It can only support while it is there on inside their shoes. Little bit of the gait cycle, as we said, that it is divided into two phases, the stance phase and the swing phase. 60-40 is the division of the stance phase and swing phase. There was in our time, the classification was different. The old classification was more about heel strike, foot flat, mid stance, heel off, toe off, mid swing, heel strike. Life was simpler between our time, and now the new gait analysis is called as RLA. That's the new nomenclature that has given, and the different phases of cycle are divided into initial contact, loading response, mid stance, terminal stance, pre-swing, initial swing, mid swing, and terminal swing. So little bit easy if you try to see the stance and the swing phase is common. It's obvious when you are walking, the heel will first touch the ground. So that is where we are talking about the initial contact. Then we see the loading response of the body. There is a transition between when the heel touches to when the heel is ready to load your body. That is the loading response. At this point, the body is behind, not on top of your heel. And as the loading response add, the body comes on top of the heel. So at that point, it is a mid stance level. Then in the terminal stance, the mid stance level is for the stability to provide the pre-swing and swing of the other leg. So during that period, the body is stable on that. And once the other leg comes in the contact, your body goes in a forward positioning where the heel is behind and the body is ahead. That is the terminal strong. And then the pre-swing happen where the body start leaving the ground. Once it completely leave the ground, that is where the initial to mid swing happen. In the terminal swing, the body again passes through the midline of the body and go ahead of your body, and again the heel strike or the initial contact will happen. I hope it is similar. It is very difficult to see the whole body from the top to the bottom, but if you concentrate your eyes while somebody is walking on the feet, you can understand the gait cycle much better. Don't try to see a lot of things first in the upper body. One or two times you have to, whenever you're trying to do a gait analysis, always remember, don't start making assumptions when they start walking up. सबसे पहले जब भी आप start करते हैं any examination, you start with the history taking. You know what are the medical problems, but trust me, the best gate analysis happen when the person is entering the examination room or walking inside your clinic. So if you are the treating doctor and you're sitting inside the cabin, come out and ask the patient who is sitting in a waiting area to follow you to the examination cabin. At that time, the way the patient is leaving the chair, standing and walking to you would give you the picture inside what the patient really have the problem. For the proper examination, you need to make the person walk for 2 to 3 minutes, and then you see once the muscle is tired, when the subconscious mind hits in, and the patient is comfortable with walking in front of people who are observing, then they start walking in a more natural stance. And this thing, always make sure that the hands that they have are free and not inside their pocket, or they are not holding purses, not holding mobile. They have a habit of not leaving mobile anywhere and everywhere. So ask them to leave everything, walk relax, bare feet only. Start observing the most common thing that you can see in the gait: the pace, the stride, the swing of the body, right, left swing that is happening, the neck position, the shoulder position. 40 to 60% of those things much faster and easier, because the joints are more free to move around. And then once you are comfortable with that, either you can see at eye level or you can sit down, lower your body, and then observe only between ankle and the knee how those two joints are behaving. For doing foot examination and gait along with that, try to make the person lift their trousers or pajamas till at least above the knee height. So if you can see the internal and external rotation of the tibia while you're trying to observe the feet, it is much better way of examining. Loose clothing or clothing in which there is no hindrance in your eyesight is much better. So try to make sure that there is less disturbance between your eyesight and their clothing and their feet, and sit a little lower level and observe their feet, how they are going. While you're doing that, you can see the sounds that the feet are making. If the person is a very flat-footed person, it might give you a sound of a vacuum kind of a thing. You can see a hard heel strike, you can see the foot rotating, you can see there is a skating, there is no good clearance of the feet when they are walking around. So observe all those things while they are moving. So this is a better representation of various stages of walking. You can see how the heel is touching the ground, lowering onto the ground, getting into the stability position. Then this is where the heel is behind and the body is ahead, and then the heel is lifted off the ground. It is far off from the body. So you can understand that during these phases, the glutes and the posterior part of your leg, the hamstring and the calf, the Achilles tendon, comes into action to provide you a proper locking mechanism so that your body can lower and take the load on. Then in the mid level here at this point, your quadriceps is also providing you the progression. It needs stability of the knee ligaments and meniscus to load the body ahead. In this there is the whole stabilization fully grounded. If it is rotated or anything, you will have trouble. Then in the heel of phase, mostly the glute and the hamstring will again do this thing. They become the agonist, and the movement start happening to the level that the glute started flexing, and it is allowing the hamstring to come off the ground. At this point, the other leg is the stabilizer. This leg is just lifting and clearing the ground. In the toe of phase, if the body is not lifting, then you see here the plantar flexion and the dorsiflexion aspect is involved. So you have to see whether they have a good range of motion in plantar flexion and dorsiflexion. If they don't, they can't clear the ground smoothly and without any hindrance. So again, in the swing phase, the early swing is 60 to 75% of the total swing, and here the hip extension happened by 20 degree. Iliopsoas is the one that is doing the rotation of the hip also and providing the movement. The knee flexion is around 40 to 60 degree at this point. So here the quadriceps is working, and plantar flexion to dorsiflexion is almost 20 degree happening at the ankle. Now, when the mid swing happen, it is in the phases of swing phase, the 40% that we are talking about. 75 to 80%, 85% of that cycle is the swing, mid swing, and the 85 to 15% is that last late swing. So early swing is the most important part, how the body lifts the ground up, and what is the role of knee, hip, and ankle during that is important for us to observe. If we don't have a proper gait cycle, there can be various contributing factors. Some are on the foot side, but many are on the upper body side. It's about the hip, it's about the core, it's about the shoulder. If you have a rounded shoulder, if you have a frozen shoulder, if you have a forward neck posture, if you have cervical spondylitis, if you have lumbar spondylitis, it changes and deflect the motion of your body in a very different way. So each and every this thing increases the tilt of the body balance, how the legs are stabilizing. When we are talking about the biomechanics of the things and the biomechanical problem and the things from the foot side that we locate while we are seeing the gait is the pronation, or rather overpronation. In overpronation, it's in a very layman term, it's inward rolling of the foot. The foot rolls too much inside, and there is a medial shift of the body that happens. Now when that happens, if you see this picture, the neutral foot alignment is where the calcaneum, if you try to make a few dot onto the body, choose the center of the calf muscle where the calf belly is, in the center of the tibia posteriorly, you try to make one dot. Then at the end of the Achilles, where the Achilles tendon is getting attached, you try to make another dot over there. And then you can choose a spot which is, as per you, the center of the calcaneum. Now they all should coincide in a straight line, so then the alignment is good. You can do an imaginary this thing, and if you are new to the like foot examination, you can actually make some marking dots and try to keep a scale parallel to it, and you will understand there are some positional goniometry that can help in doing so. So these days goniometry and all those things practically is little difficult to do on a OPD basis where you have to see multiple patients. So you can go for foot posture index or visual analysis of the foot, where you can check whether the calcaneum is actually aligning with the tibia or not, or it is aligning with the Achilles tendon or not. So if there is a mild pronation happening, then the angulation towards the eversion is the thing that started increasing, and the calcaneum is everted, where you will start seeing there is a drop of all the muscles and ligament towards the medial side. In overpronation, I've seen people completely overturn feet also to mild overpronation. Now certain time when you see them in sitting, this calcaneum positioning is much better in non-weight bearing, but on weight bearing this positioning goes off and the stability is not there. So that's why they have lot of pain and discomfort in walking, but it is not permanent when they are sitting and doing things. For people with arthritic pain and everything, weight bearing and non-weight bearing don't make much of a difference. Foot, as it is the bottommost joint, it becomes the foundation of our body, and the whole kinetic chain of our body is dependent on the foot alignment. So if we have a lot of overpronated feet, then what happens is to support the overpronation, the tibia has to internally rotate, which gives you a knock knee or a valgus knee kind of a appearance. Then what happens is if this 2-3 structure is getting inverted, then the femur has to support it by getting into internal rotation and causes an external rotation or a pelvic anterior pelvic rotation of the hip complex. So all this thing keep on going from top to the bottom. Now if this person comes to you say with a knee pain, and you do your best in terms of applying your physiotherapy skill, knowledge, mobilization, strengthening, training, and everything, the patient will feel good while you're doing everything at the clinic. They will feel the pain is less, the mobility has improved, and they feel confident to go. But what will happen after 24 to 48 hours as they start moving 8,000 to 10,000 times, if they are an active person, their knee has rotated internally. So your 10 to 20 repetition or giving all kind of electronics and all those things has reduced down the inflammation, but the root cause was still at the feet where the foot was pronating in every walking cycle that is there. I have seen thousands of cases where knee replacement has been done for people with severe flat foot and nothing was done to provide support. So these kind of a people after 3 to 5 years again experiences the knee pain. They don't have increased mobility. The only criteria of getting a knee surgery done is that you want to be more active, mobile, you want to move around, you want to do your chores by yourself, you want to be independent. So after doing this expensive procedure, going through all the medical pain and bills and everything, if you are still homebound, then what's the purpose of getting the knee replacement done? It's an expensive painkiller actually that you are buying. And traditionally, it is wasting a lot of time of physiotherapy and physiotherapists, because no matter how much you try to give them mobility and stability, they will still not be regaining it anytime soon because the pelvic tilt or the feet alignment has not been corrected. So while you're focusing on knee rehabilitation, try to give mobility exercises for the feet as well. If you see any kind of arch deviation, low, high, uh, flat, if you don't have excess of orthotics, still try to do a lot of mobility exercises, do manual mobilization of the ankle complex and give them strengthening of the ankle also. And definitely nowadays you do a lot of core strengthening for knee strengthening before you start quadriceps, hamstring and glutes. You try to stabilize the pelvis, stabilize the upper body, see if they have a rounded back, then work on those joint as well. So knee joint to me is the most stable and the innocent joint in the mobility disorder, but because it's a weight bearing and a connector joint, you have more issues at knee, but they are not initiated or started at knee. So what is the point of focusing our physiotherapy time on the knee when it is not the root cause? So try to find what is the root cause, whether the upper body has taken the toll on knee or the lower body has taken the role on the knee. In opposite to pronation, if you have a lot of supination, the calcaneum goes into inversion. There is an abduction and dorsiflexion of the talus bone that happen. The talus rotate outward. So you will see these kind of individual, if they are wearing a shoe or something, the lateral aspect of the shoes is worn out. They have frequent sprains or instability kind of complaints that they experience. They have a bow leg or a varus knee that you call. There will be lateral rotation of the femur that has happened. So you will see the curvature of the bone going outward. And most of the time, these people, once the tibia is rotated and curving from top, at the bottom, it is curved inward. So they look like that they have a flat foot, and people start advising them on insoles and orthotic that is meant for flat-footed people and worsen the problem. They have to be treated as a supinator. The corrections on the insoles and orthotic has to be targeted towards the supination control, and they should not be given a pronation control shoes that if you send them to shops like A6 and all, they will try and sell them a flat foot shoes. But being a doctor, you know that the biomechanics is different and the appearance is different. So you will correct the biomechanics, not the structure. In these cases, they have a flat back or a posteriorly tilted pelvis. So people with chronic back pain might be having a very stiff midfoot and a stiff arch. A very simple way of noticing that is you make the person stand in front of you. Slightly dip down but regains the shape. It is stable much faster. Then if they are doing any jump test or landing onto the ground, their landing is not soft for high arch people. In high arch people, when they stand on single leg, the bone positioning, the arch don't collapse at all, and they will find their stability more onto the outer fourth and fifth toe and the outer calcaneum rather than on the mid side. The flat footed people will immediately start turning towards inside, and they get the stability at the medial end and the first ray. So that's the difference between those two foot type. Many a time people ask that ये मेरे साथ ही क्यों हो रहा है, मुझे क्यों flat foot है. So there are various reasons that lead up to a overpronation or a flat foot problem. Originally, if you see, the surface of the ground is not absolute flat and hard. So there is a theory called as nature versus civilization. It is said to be believed that our feet were not designed to walk on hard and ungiving surfaces. It is designed to walk on soft and giving surfaces. But over the period, due to civilization, we are having everything which is flat, soft, hard. So when we are walking on it, the surface is not giving us any shock absorption. So our feet has to overcompensate to cause a movement. Then there are habits like wearing unsupportive footwears, wrong size, wrong type, wearing too tight, too loose a footwear can cause you trouble. Then there are some genetic factor where your parents have a flat foot, your family has a history of flat footedness, and that runs in your genetics as well. Then there are certain people who have postural issues, as I explained earlier. Their upper back and spinal issues are there that can also cause them to have these problems. Age can be a determining factor again. As we grow old, there is a long time usage of our feet. We don't take care. Even people who are fitness enthusiasts, and I've seen it a lot in my 3 years with Goals and Thal workers, people love to do upper body. People like to have a good dole shole, but they don't want to do leg workout. And if they do leg workout also, there is no exercises for the feet that are there, or they do it on a regular basis. So we are overusing and under treating those joint also. And that soft shoes, the clumsy shoes, the flexible shoes, shoes like Skechers and all that don't give you any shock absorption or controlling effect, are causing more damage. Even what they try to sell as arch fit and all those things, they are all soft cushiony support. So if the shoe don't have a hard heel counter, it cannot help and support you to keep your body in a right direction. Sometimes there are people who have repeated falls and injuries. They can also have these kind of overpronation at a later age. In my experience, I have seen more of the females developing adult acquired flat foot for the reason during the course of pregnancy, your body release a lot of relaxin hormone, which causes increased laxity in the muscle throughout the body. And during the course of pregnancy, there is a sudden weight gain. Foot itself is a very strong structure. I'm not saying that if you are overweight, you will get flat foot. But what happened in most cases that people gain weight gradually, not even knowing that they are gaining weight. So weight increase happen very gradual. Now imagine that you are new to a gym, you go first time, and it is difficult for you to lift 10 kg of weight. But you go 2 times, 3 times, 10 times, 20 times, and then After some time there is hypertrophy of the muscle and you can lift 100 or 150 kg also. So as we put weight onto the muscles, it hypertrophied itself, it make itself stronger and then can take more load much easier. So foot can adopt to weight gain, but it cannot adopt to sudden weight gain. If you're a lean and a thin person and you started muscle building and you started lifting 100 200 kg weight to bulk up your muscle, you will be doing 2-3 repetition, for which the bar and the loading and everything is shifted to the front of the hands and all those things. But the foot is ultimately where you are squatting and loading. So foot cannot take that much of weight completely because you're not doing any other exercises for the feet. So there the arches have started collapsing much faster. People for hormonal issues and other issues gaining weight quickly will have trouble. Pregnancy during the second and the third trimester, the weight gain is very, very sudden, and then it can also cause trouble. And post pregnancy, if they cannot shed that extra fat around the body, then again that weight is not something that the body was having it throughout the life. This is a new weight, and then again the dynamics of the muscles and tendon and ligament start disturbing. So why we are talking so much about overpronation, supination and all those issues? Because all this thing combined gives you a lot of foot issues, specifically plantar fasciitis that you see on the regular basis at your clinic. Then you have Achilles tendonitis, you have Morton's neuroma, you have sprains. Turf toe is basically first metatarsal thing. Then you have shin splints and bunions. Now, these are few things that I'm trying to cover today. Will give you little insight on the practical side, what to do when you're doing. So all of you must be knowing what these are. I'm just trying to give you on the podiatry side what you can do when you see such cases. Moving on to the joint that is most near and dear is the knee joint. At the knee joint, you can see IT band syndrome, you can see chondromalacia patelli, you can see runner's knee, jumper's knee, you can see a lot of patellofemolar pain. You will have stability issue, the cracking sound that the patient keep on telling you, some pain around the patella, swelling around the knee, difficulty in load bearing is all those things that you will see on the knee side. If you go towards the leg, then you can see leg length discrepancy as one of the major problem. If you have a unilateral overpronation, obviously 4 to 5 degree the ankle is down, and 4 to 5 millimeter the leg will also be down. So as soon as these started happening, it can go that way. Now in other cases you will see apparent shortening in many cases of single leg knee replacement done. So one leg is straightened up but the other is still in bent format or the degenerative state. So there can be difficulty in redistribution of the weight, and the curving part is still there on one side and one side is absolutely straight. So that will cause a true shortening of the knee. Any traumatic injuries, fractures, falls can also lead to true shortening. Another thing is AVNs, avascular necrosis of the femur can cause leg length discrepancy, but it's a true shortening, but hardly easy to correct. So mostly I avoid correcting. They have a lot of pelvic tilt and all. So we do under correction in those cases. In cases where there is true shortening by trauma and other factor, then we do complete supplementation. Why we don't want to do exit correction in AVNs? Because it will push the bone too much inside towards the hip, and then they have more issues on the pelvic side as well as on the femoral side. Then comes to the spine and the pelvis. As I said earlier, because of the domino effect of the foot, If there is overpronation at the ankle level, there is internal tibial rotation, there is knock knees that is happening causing anterior pelvic tilt. So you will have SI syndrome. You have a lot of patients having regular SI pain, sciatica that you call pain in the posterior glutes can be there, IT syndrome you will see. Then they are generally fatigued much easier because biomechanically, if you see, like as I told you in the beginning, that how you see different car park, if you don't have a good wheel alignment and you're driving a car, you will never have control on it. You're very susceptible to accident because at the time you want to have control on the steering is not taking you to the direction that you want, it is taking you in the opposite direction. So you don't have good control on your feet. You can have injuries, fall, fractures. Mostly in case of geriatric, it is very important that their foot alignment is taken care of, irrespective of pain and discomfort. In India, people do orthotic treatment only for pain. That is the most gruesome thing to do to your body. So I try to set the base for you all. We covered a lot of thing in terms of how the structure works, how the joint works and everything. At this point, are there any question that I can help? Anything that is not clear or misconception is there? When I try to cover too many things, sometimes I miss out on few things, but it's okay.
Dr. Saurabh? Ma'am, you can.
Okay, there are some questions.
Ma'am, you can find it in this one chat box.
Yeah. So there is one question from Shivanshu. What we do for making an arch in somebody if insoles are if insoles not work. So I think by the end of this, you will understand what actually is an insole. And if it is not working, it might not be an insole, it might be an insert that was given. But there can be some exercises that you can do. But what you have to understand, you have to make your leg anti-gravity strong. If you have like a poor Vilnas mechanism, if you have a poor control on your body, you have to make them anti-gravity. Now imagine your spine. You try to do back extension exercises for your back patients who are having a lot of back pain and this thing. How much success ratio you have in strengthening your rhomboids and posterior spinal muscle? So if you have good success on a spine, you can have good success on the feet. But 90% of the time, I see the long-term exercise program failing with patients. They don't comply to it once the pain is gone. So the focus on exercises is still the point you are having pain. If they don't follow it through, then there is no permanent effect that can be done on the foot structure without using orthotics. But if you give them orthotics, it is much easier for them to comply to exercise regime. And that exercise regime can be simple walking that they cannot do on a regular basis. If it is comfortable, people love to walk. They can add up walking, jogging, gymming, games like badminton and all to increase their mobility. So you don't have to give them particular exercises on a regular basis, but these normal activity can help in improve their foot structure. But try and wait for understanding the insoles as well. What is actually an orthotic insole? You ask, so Pooja asked a question about difference between functional and the mechanical flat foot and how to examine. There is a whole 1 hour lecture on, I have to like physically give you those examination protocol, but there is a way. There are 6-foot type. Once you understand the foot type from the hind foot to the forefoot, there are various combination of foot types where are there, so you can get to know what is a functional and a structural flat foot, and then accordingly you can design the exercise program. In certain foot type the exercise program works and other don't work, but there is a way to examine. I can only help you while we are doing physical workshop, because you have to see the feet in your hand, and then you can determine whether it is a functional one or otherwise. uh, Uh, there's a question from Dr. Sharad Mishra about severe arch pain, what to do. So I'll give you some guidance in the upcoming slide. What exercises to enhance ankle stability, mobility. Again, it will come in the later aspect. So I think this is covering navicular repositioning technique. That will be done by orthotic correction only. So I'll explain you that as well. Okay, so good break. Now we'll do the examination. So best way of doing examination is like this. अगर आप कुछ बुरा देखोगे ही नहीं, सुनोगे नहीं और बोलोगे नहीं, तो वो सब कुछ ठीक है. So I do all my examination like this. Okay. So back on the subject, the best principle of doing foot examination is divided, as per me, is into 3 aspects: look, feel, and move. Now, before we do any physical examination, we need to understand the audience that we are addressing. So that's why a one-to-one interview with the patient is very important. You start with their basic data, name, age, sex, occupation. यहाँ पे जैसे आप when we are going deeper into the things, you can understand, though the bone structure and the number of bones are same, but the function of bones in male and female interchange because of their body dynamics and mostly the pelvic dynamic. So there are certain problems that the male will experience more and certain problem female will experience more. So sex is important on that aspect, or rather gender. And then what you see is their body weight. Body weight, when you are seeing, just don't assume that they are obese, that's why they are having a problem. Try to understand if the increase in the body weight is recent or it is through year. So again, we have covered it already, how it differs into the clinical presentation and the expectation of results and all those things. Then try to understand their occupation or mode of transportation also. In Bombay, it is important for us to ask them how they travel. Are they using public transport? Are they traveling through train? Are they traveling to the bus? Or they use their own vehicle. So what happens is, when they are using public transport and all, there are people who are standing in trains for about 1.5 hours. So it's very important for us to know that way and see what footwear they use to travel. If they are standing in a, say for a female is standing in a heel and going to work every day, it's gonna have some repercussion on their body alignment and everything. Many females have broad feet and they don't want to show it up, so they keep on wearing tight shoes. It compresses the whole the transverse arch area and causes bunion and other deformity to happen. So it is very important to see what kind of a profession they are. Now, if their life depends on wearing a stilettos and their day-to-day work cannot happen without wearing those things, then we have to adjust with what we have and try to give them as much comfort as possible. So very first thing, when you see the patient, as I told you earlier, also try to have exposure till the knee. Do a journal examination in which you check the skin condition, you see the coloration of the feet. People who have diabetes and other issue, you will see patchy or black discoloration on them. See for any scar or posterior injury, you can ask them if they have any implants, because sometimes it happens that in the previous history they miss out on certain sprains or certain procedure that is done on knee specifically. उनको लगता है अभी हम foot के लिए आए हैं, so I have to give history alongside the feet, but there can be some injury over there. Then they have some old scars. They can cause a lot of keloids and coagulation, tightening of the skin at that point. So if there are, you understand as a physiotherapist, if you have a knot in the calf, how much pain and discomfort it causes distally. So if there is a scar, it can cause permanent damage in the range of motion to the distal part that they are positioned. So that's why you have to see, you try to touch the scar and see whether it is superficial or going deeper into the tissue. Check for any muscle wasting that is there. In terms of the girth of one calf is more or other is less, then you will know that there is a favoritism in which they are using one leg more than the other, and try to understand what it is that is causing hypertrophy on one side. There are people who have neural involvement, polio and other cases. So obviously in that case also you will see a difference in the girth on both the side. Then you see if they are using any supporting aid like walking stick, tripod or any other thing, and whether they are using it just by themselves or it is being prescribed to them. So certain neuro cases it is good. Certain cases because they don't have a good stability or control on their body, people start giving them sticks for support and everything, which in another way is a problem for proper gait and posture and for proper mobility of the feet as well. So see whether they actually have that much disability to use a stick or not. And if through exercises and balance training you can get them off it, if it is not medically needed, then it is much better. You'll have better results in their outcomes. Then the second part of it starts with the examination and temperature. You have to see whether एक सबसे पहली चीज है, whenever you are trying to do a foot examination, try to sit lower to your patient. So if they are sitting on a chair, try to sit on a lower stool. If you make them lie down on a bed, make sure that the feet is off the support, like off the bed, it is hanging down or something like that, or they are first sitting and then you do the examination in a standing. But don't stand on top of their body and try to examine the feet from the top view only. Top view is always there, but try to see the bottom of the feet. So try to see if there is any corn, callus, ulceration, dry skin, any patchy spot. If the arches are too clean, it means it is a high arch person. They are only taking load on the heel and the forefoot area. You will see thick calluses between second and the third toe. So it is very determined about the gait that they might be having on a regular basis. If there is a flat-footed person, you will see the whole feet is dirty or darker in color. There is dry skin around the heel. There are more calluses at the end of the toe and on the side of the nail also. You will see that thing because they overpronate all the time. So the medial side of their great toe will show thick skin or calloused skin, and their corns and calluses are more in the first ray zone. So that is very common. Then you try to, once you lift the leg in your hand and try to see and examine the feet from bottom or see the look of it, you will be able to determine whether it is too easy to lift, whether it is like dry, like you're lifting a dry log of wood, or is it too heavy. it is too puffy, it is too tight in your this thing, you will understand what different problem it can have. So say in case of diabetic people, if they have poor blood circulation towards the periphery, the woody feeling, the light feeling will be there. One feet might be more, one is less. So in these kind of a case, and if they are a known case of diabetes, try to do vascular examination, try to refer them to a doctor who can do proper checking in terms of their nerve condition velocity test. They have to do the Doppler test to see whether there is any coagulation and all those things are happening or not. This kind of people will have neuropathic sign as well. They will be complaining of numbness, tingling, burning, and other sensation. I will cover diabetic foot a little deeper later on also. So these things you have to see and notice when you are seeing such patient. Then you will try to move all the joint, try to see the flexibility, how they are moving, are they too stiff, too tight. See, you put your hand behind and see whether the calf is too tight, where the Achilles is too tight. Palpate around both the side of the ankle to see the arteries, dorsalis, pedis and all, whether there is proper rhythm on both the side or not, and it is same. That is also important. In the move part, you basically try to see the active and the passive range of motion. Ask if the feet is not off the ground, say if they are sitting and they are lifting it up, then you can do that active and passive range of motion. If you make them do active and passive range where the body is touching the bed, then the active and the passive range of motion will be less. So it has to be lifted off the ground. Something should not touch them. Either their feet is hanging off the bed or their feet is above, or you put a calf raise. Like if you're doing examination in supine lying position, keep like a pillow under the feet and see if the ankle is allowed to move full range or not. Otherwise it makes no sense to do the foot examination when your itself is blocking the range of motion. So, and then after that, if you find like they are doing the best but it is not in the normal physiological range, then you can try the passive range and see whether actually the movement is restricted or lost, or there is a movement which is present but there are some hindrance to it, maybe a tight muscle, maybe a lack of strength, or maybe a bony block that is causing them the trouble. So once you start the treatment, you can focus on those aspects, what you feel could be the issue or restriction that is causing the problem. Then next happen is, after doing the physical examination, you try to see foot posture index, goniometry. These days most of the people are not doing. There is some devices like active force. You can put it on your hand and then you try to do the movement. It gives you, on the app, gives you the digital data about what is the range of motion, and even the strength also it gives digitally. So something like that, if you want to use, you can use that, or you can see on the visual side what is the range of motion. To me, I don't compare something to a normal range of motion, because it is very debatable to decide what should be the range. How many people you have examined to say that, okay, this is what every person has in normal and these are not normal ranges. So I don't go by the book what they say. I try to compare between the right and the left foot of the same person. Are the range of motion similar on both the side? Then that's the natural range of motion of that person. If the range of motion is good on one side and not good on left side, it is a loss on other side, and the good side is what we have to achieve. So for me, I will try to be with that patient rather than trying ki main itna kar sakti hu to aap bhi kar sakte ho. It will happen over the period, that if your protocol is right and your exercises and your orthotic correction is working, their range of motion improves to what you have initially seen. But at that point, don't push your patient too hard that you have a lot of range of motion issues and all those things. So that was the representation of goniometry. If anybody like to do it, you can do that. I have not done, I don't know, since 2006 or so. After leaving the college, I have never done any goniometry examination on my patients. So these are the normal ranges. Dorsiflexion is mostly 65 degree, more or less. And when we are talking about subtalar joint range of motion, you can do it visual. It is 20 degree to 10 degree, but better way of doing it is 2:1 ka ratio hona chahiye. If the inversion is more and eversion is half of it, then we are in good. So the subtalar mobility is in good range. When we are talking about the TMT joint, then we are talking about inversion and eversion at that particular joint for 30 degree to 20 degree. So there is slightly more inversion and slightly less the eversion component at TMT joint. Then ankle range of motion, dorsiflexion is 20 to 30 degree and plantar flexion is 45 degrees. So again, almost 2:1 ratio is there, a little more than that. So if that is not happening, in cases of say high arch people, the dorsiflexion range is further decreased, and the plantar flexion is increased or same, and certain cases where there is mid foot stiffness and tightness, then it is decreased also. So movement restriction are very common with high arch people or supinators rather than the flat foot. They are good in terms of range of motion, they just don't have good strength to cause the windlass mechanism and move around. Then you try to see the forefoot and rear foot alignment as you go behind, and remember the axis and plane. We need the body in a anatomical position. So when we are standing normal, the foot is slightly abducted. Now if it is too much abducted, too less abducted, the rear foot and the forefoot is not in synchrony. So how the body work is, where it works like a lock and a screw. So if you take a bolt and a screw and you want to tighten them up, it goes in opposite direction. So the hind foot, once it is stabilized, the forefoot goes onto the opposite direction. That is called as resupination. So this locking and unlocking, if it is not happening in the same way or manner, then it's a problem for us. So to test that, we just make them lie down on the bed and check the correlation between the positioning. But it is more of a positional examination rather than doing any gonio or any other angulation kind of examination. We have talked about Villas mechanism. So the same thing in Hubser's or check test. You, instead of the patient lifting the toes up, you are the one who is lifting the toes up, and you're lifting only the great toe specifically. So you check at this point whether the Villas mechanism is good or not, and in this particularly you are trying to determine the hallux limitus and rigidus. Better way of doing that is you make the person sit in front of you and lift the foot, stabilize the midfoot area, and then try to move the great toe and see whether the great toe is going to 90 degree or above or less. So if it is a limitus, if you in the same position try to do a little gliding, move the first ray up and down a bit, and then try to do a little rotation, try to do a little circumduction of the first ray, and then if the range of motion in the same test improve, it is a hallux limitus. So it was limited by the tightness of the tendons and ligaments around the bone. In a case of hallux rigidus, there is no change in the movement after you do mobilization of the first ray. So it will be rigid even before and after. Then comes the supination resistance test. What you do is you it's little again observatory kind of a thing. There's no objectivity to it. What you need to do is you do this test to see whether the orthotics will work well or not. So you make the person stand and you try to ask them to stand and put pressure onto the feet, and you try to see how much weight they can put onto your finger while you're trying to resist or support them. So this is just to see the mid arch thing. In supination resistance test, uh, if it is negative, what you try to do is you don't try to give high arch orthotic. You try to give them a moderate or a low arch only. You don't do full contact orthotic in these kind of cases. Gait analysis, I think we have tried and uh, discussed it while we are doing the normal gait cycle. So as we are doing the gait analysis, again, I reiterate, you do it in the comfort zone of the patient. You try to see from ankle to the knee, try to see the pelvic side of the thing, try to see the hip rotation of the foot, try to see whether the knee is properly moving in conjunction to each other, the strap length and the stride length of each and every leg. Try to see if there is a lineage on one side. Many of the people have pelvic rotation, anterior and posterior. So while they do so, their body tilt more to the one side, and they sometimes show hyperextension as well. So if you correct the pelvic tilt or the foot alignment, the rotation part also get taken care of. Then the other neurological gaits, antalgic gaits, and all those things you understand, you might have studied a lot. Uh, most of the time, what you see or what we study in gait at the college level are only true for neurological cases. When it's a MSK gait, everybody and anybody will come with all sort of postural and gait deviation. So you can't even define after a point ki which gait it is. So it's better that you individualize in terms of their symptoms. They are coming with a hip pain, they are coming with a sciatic pain, they are coming with a SI joint dysfunction, or they are coming with heel pain, knee pain. सो वहां पे आप ग्रिड मेजरमेंट करते जाइए उस पर्टिकुलर जॉइंट पे, उसके ऊपर का एंड देन उसके ऊपर का, एंड सी एट विच कॉलम द नेचुरल एनाटॉमिकल पोजीशन और द लाइन ऑफ ग्रेविटी दैट कॉजेस आर planes are getting merged or crossed over. So say if I'm standing like this and my shoulder is lying, so I should have been in this zone, but my neck is in this zone, my shoulder is in this zone. So I'm crossing 2-3 different grid line of gravity, and that's why wherever I'm crisscrossing, wherever I will have muscle tightness, pain, and discomfort. So that's why gravity to the planes of our body is very important. Posture analysis, you have to do from all three planes, front, back, sideways, and see how the body is doing. Now, in terms of foot, we do foot posture analysis differently. So it has 6 components to it, and we give number in plus and minus. +2, +4, +6, plus करके आपका जाता है. So in a case, if you see the first representation, the first segment that we see is called as the Taylor head position. Now what you do is you put one thumb on the medial side of your subtalar joint. So you put one thumb on this side and the index finger onto the other side, and you try to palpate both the end. If you feel the talus is more prominent on the inner side, then it is a +2, +1. Okay, and if you can palpate both on the similar side, the talus is equivalent, you don't feel too much of a bulge on any of these sides, then it's a neutral or a 0. If it starts shifting to the outside, you don't see much of deviation this side, but you see it going outward onto the lateral side, then it is -1, -2. So neutral, -1, -2 is for supination, and for pronation, it is ++. So one number is given to here. So supposingly in this thing, I give +1. Now I go to this one. In this dimension, what I'm trying to see is superior and the inferior lateral malleolar curvature. So you see the lateral malleus over here and top and bottom. If it is a pronator, there's something wrong in this thing. So in case where you see too much of a curvature on these side, again it goes to +1 and +2. So 1 + 1 we can say over here. Then we come to the inversion and the eversion side of the sit. So if it is a flat foot and the body is severely everted, we will say +2. If it is mildly everted, we will say +1. And if it is in the straight line with the calf and in the center of it, then we have to give it a 0. So we have given 1 here, and now 2 here. So it makes it 4 +4 for a pronator. Now we see the bulging in the navicular joint. So at the outer side, mostly in the pronator, what we see is there is deviation on the other side happening. Eversion is there. So you will see more bulging on the inner side over the navicular joint. So here you will again can give 1 if it is mild, and if it is severe, you will give it 2. Then you go to the medial longitudinal arch. In medial longitudinal arch, if it is completely flat onto the ground, the great toe and the heel along with the midfoot is all in same plane, you will give it +2. Our total score has risen up 1 to 4, 5, 6, 7. And now we come to the rear foot. When to see it behind, if you see it from behind, and if there is a case of severe overpronation, you will be able to see, if you're just standing behind the patient, you will be able to see 4th and the 5th toe as well. And sometime in severe overpronation, you can see 3 toes outside. So this will keep on going inside, and the forefoot abduction keep on increasing. In that case, you will give +2. If you can see 2 to 3 toes, then it is +2. If you can't see anything or you see very less of the grade 2, then it is minus. So overall, if we say we have given 1 + 1 2 plus 2 4 plus 1 5 6 7 8 9. So we are somewhere sitting at severely pronated foot. That is how this scaling was done. You can do numbering, or you can just see this 4 angles of observation. Don't give a number, but see all these 4 angles of observation, and it will help you to clear whether the flat foot is because of overpronation or due to excessive rotation of your tibia. So in that case, the person will go on the minus side on other thing. But you might be just giving for low arches, you might be giving +2, but all other things are in minus. So overall score might be 6, which is a pronated foot. Just to be understanding, if we see a foot as a high arch or a say this person is a supinator with compensation, not a pure case of supination. So unka teller head will be given -2. It is here again malleolar will be given -1, -1, -1, +2, and then again -1. So all minuses will be together, and then you minus that 2 over here, and you might be landing up into -6 kind of a range. So that's how it helps you to determine when there is a confusion and there is no classical representation of flat foot or overpronation to a high arch. Okay. This is little confusing and a little difficult to apprehend, but it's only because we are not doing it on a physical basis. On a physical basis, it is very easy to mark those things, and when you can observe somebody else standing in front of you and you mark those things, it is much easier. Now, what we tried to establish so far is the basic anatomy, how the body looks like, how it comes together to provide certain function, and if the function is not carried out properly, then what are the common problems that we can see, and how to examine those body part in a proper fashion to come to a conclusion that what pain is due to what cause. The pain might be something which is in front of us, but the condition might be due to something which we are not knowing or looking when we are doing the uh, hearing part. So that's why we need to look and feel all the other part. So most common condition that we will discuss right now would be plantar fasciitis. I think on your OPD basis, you see a lot of cases where people will come and tell you that they have heel pain or heel spur or plantar fasciitis. Now they do Google and they come to you and tell you. So basic, if you want to determine the stages of plantar fasciitis, in honesty, the right word is plantar fascinopathy, not a fasciitis, because it is very hard to determine whether there is a inflammation happening, itis happening inside or not. So in most of the journals right now, they have started using the term plantar fascinopathy, but for the ease and for common lingo, plantar fasciitis is still is in use. When somebody comes to your clinic and they say that past 2-3 weeks I'm having pain in my heel throughout the day, it is more severe in the morning when I get up and I put my feet onto the ground. It feels like I'm standing on a piece of a nail or something, and it is agonizing. I can't bear it. Then that is stage 1 of plantar fasciitis, where there is a recent inflammation. So you try to ask history around the event from which they have started experiencing the pain. You could hear histories like there was a family wedding, so we were preparing for Sangeet and I started dancing. I was dancing bare feet. I twisted. It was okay. After the wedding was over, I now started having the pain. Some can be in Bombay, there is Garba happening. So during the time of Garba, it do happen. Then there are people during the rainy season don't want to wear new shoes or buy a new shoes. They keep on continuing with old worn out shoes because they don't want to ruin it. Now the old worn out shoes was not giving them shock absorption that was required, and all the load get transferred to the fascia. Now the fascia has to work the job of stabilizing the body along with increased shock absorption need because the shoe was not doing it. So the plantar fascia get irritated. People during the time of shifting start loading stuff by themselves. They pick heavy objects. Then their habitat, once it is changed, their sleeping cycle, eating cycle is disturbed. So during those course of time, also during wedding, when they have unnatural lifestyle or routine and too much on their feet, all those conditions are uh, the history that you will receive while you're seeing a plantar fasciitis. Now, because it's a recent development, people like this in the first incident respond very well to basic NSAIDs like painkillers, some D3, B12 supplement, cold fermentation, wearing a compression support, something, a plantar fascia sleeve kind of a thing. They do well if they take few session of physiotherapy. And as a physiotherapist, if you can do cold fermentation, ask them to do cold fermentation 3 to 4 times a day. And you do calf release, Achilles tendon release and mobilization of the feet, they will go without pain much easier. But if they come after 3 months and then their complaint is every day when I get up in the morning since 2-3 months, my heel hurts as soon as I put my feet on the ground. First few step is so painful, but then I get used to it. I can walk around. Then it means that they are in an intermediate state where the plantar fasciitis is now converting into a calcaneum spur. So if there is a inflammation at one particular point, if you see the bottom image where the red zone is there, if you see, it is just the attachment of the fascia to the ligament. Now this fascia has one end which is closely concentrated behind, and then it goes and fan out between each toes, and these areas are much stronger. Now when we are jogging, running, doing activity onto the feet, either we need them to be completely free or supported or shock absorbed. So now if we don't do that, we wear tight shoes, we try to wear flat chappals, or we are barefoot for a long period of time when standing, then what will happen? This area will start collapsing down. That is, in the white lines, if you in the between that you're seeing, it's the dome of the transfer arch. So that will first start coming down. Now once it comes down, it elongates the feet. If in a flat foot, what you see is when there is a overpronation, there is an increase in the length of the feet. So now the ligament is becoming shorter than what we were requiring, and because of that, it has started stretching itself at the attachment of the calcaneum. Now when that happens, there is micro trauma that is there, so the fiber get broken. It is not completely detached, so you will not feel it like a sprain or a strain, but it is continuously under a lot of duress when you are standing and walking. So this is the secondary phase, 3 months. For 3 months you are trying to stretch it, stretch it, heal it, and people mostly don't even come to you for that first 3 months. So then what will happen? There is micro trauma, and that trauma is being bridged with the help of calcium deposition. So normal cases, people say haddi bad gayi hai. The bone stop growing after we achieve the adulthood, and so bones are not further growing. It's an extra osseous bone formation. Some people claim that मैं हड्डी गला सकता हूँ, ठीक है. So technically ऐसा possible नहीं होता है, but in shock waves you can disintegrate a little of these debris, but overall the results are minimalistic. It is only useful when it is done in a very early stages, and most of the patient don't come to you at early stages, they come very late. So even with shockwave therapy, it's not gonna happen that this area will become callus free or having no extra osseous bone deposition. So what you need to do is you have to encompass that area in such a way that there is not much of a pressure happening when you're standing and walking. I'll tell you why and how. So yes, the solution is always insoles and orthotic. I have not seen many cases who get better on its own, mostly because people come to me at a later stage, so I have to make insoles and orthotic for them. And I believe that's more practical, most economical, and most correct form of handling the situation. Sometimes we have to ask them to change their shoes if they are wearing worn out shoes. तो अगर आपको कॉज पता है तो ट्रीटमेंट पता है. जो सडन एक्टिविटी करी है, उन्होंने वार्म अप नहीं किया, स्ट्रेचिंग नहीं करी, डांस कर रहे हैं, all those things has happened. So ask them to do mild training, because DOMS starts settling if you exercise once and you don't exercise later. Like there was a party and you were dancing for 3 hours, and then next day you were not doing anything, then you will have delayed onset of muscle soreness after 24 to 48 hours. And if it is on the feet side, because you're wearing a tight heel and doing that thing, then it can turn into a plantar fasciitis. So always understand the root cause and ask them to do warm-up stretching, try to wear loose shoes, sports shoes for some time. It will give the fascia the required time to heal and regain its support. Then come the Achilles tendonitis. If we are looking into the structure of the feet, the bottom stabilizer is the plantar fascia, the posterior stabilizer is the Achilles tendon. So calf, when it comes and get attached to the heel bone, it is in the form of Achilles tendon. Now Achilles tendon, I don't know how much of you are history beef and like to know about Achilles, how the name came. There was one king with the name of Achilles in old time, and he was her mother want that he lives forever. So whatever prayer she did to the god, and they give uh, a blessing that if you dip your son in a water, uh, which was a river over there for this thing, he will be unbeaten and he can never die. So he will live forever. Now the mother was a smart. She wanted and she knew that she's raising a fighter or a emperor. She wanted him to be saved. So what she did is she holded up the feet from the bottom and dipped the kid in the water on both the sides. She was holding the back of the heel and dipping the kid down. So that particular part was the weakest part in the body, and obviously the competitor of that king knew about it and he hit a arrow and this guy died. So that's why we call it as Achilles heel. That's the most vulnerable and most painful part in the body, because it is somehow not as strong and exposed too much to the outer element. So if the calf muscle is tight and you're standing and you have lack of mobility and range of motion of the subtalar joint, you can't do much of a dorsiflexion, plantar flexion. This ligament is something which get pulled. So if it is Achilles tendonitis, the pain is mostly in walking and running. You have difficulty in putting your feet on the ground. Now, next to it is the bursa. So because of the tightness of the calf muscle and the repeated movement behind, the bursa underneath the Achilles tendon get inflamed. So we call it as Achilles bursitis. Then there is posterior tibial stress syndrome also, that is there. So all those things comes in the same zone, and it is very common with people who have high arches. So they don't have a natural shock absorption, they have a hard landing, and because of the hard landing and lack of dorsiflexion, they have more strain on the posterior aspect. So for them, what you need to do is you have to support the medial arch, or you can do bilateral heel raise. If you shorten the calf muscle, the attachment of the Achilles tendon is offloaded. So if you don't have access to a full orthotic insole, at least do bilateral heel raise. You will not affect the biomechanics of the upper body, but you will temporarily shorten the Achilles tendon. The reverse of it is in females who wear too much of a high heel. So for 8 to 9 hours of the day, if you are wearing a high heel and then when you come home and start walking bare feet, the ligament cannot adopt that 4 inches of heel that you were wearing. So it was 4 inches short to walk on a flat surface, and that's why the Achilles tendon can get strained much quickly. Cold fermentation is the first line of treatment for both the problem Achilles tendonitis, calcaneum spur, fasciitis, heel pain. Both the side of the heel, if it is paining, start with cold fermentation. Cold fermentation has to be in a wrapped gel cold pack for 20 minutes, 2 to 3 times a day. You like many people on net and all start doing this rolling on a cold water bottle, but that is of no use, because your outer layer of the foot, see how thick the skin is. If you're rolling something cold underneath, how much that temperature can go inside. You can do foam roller, you can use a small foam roller or a hard ball or old seasoned ball or a tight tennis ball. You can do that micro massaging under the feet, but a cold pack, a cold water bottle or a frozen water bottle under the feet has zero effect. I don't know why it's being even used. So apply the compression around that area. So there is a vasoconstriction that happens. It will allow the body to lower down the temperature. It will lower down the swelling, and as a kickback response, there is a vasodilatation that happens after vasoconstriction, and then the blood flow towards that area increases. It take care of all the lactic acid and other deposition and flush it out. So that way, cold fermentation has to be done for any acute or subacute pain. In chronic cases, you can do hot fermentation. In diabetes cases, you will never do any hot fermentation. It can cause them ulceration and all other problems. So always ask if the person who is coming to you for heel pain has a history of diabetes or not. If it is diabetic, no hot fermentation, no hot water immersions are good for them. So don't get into that habit. It will cause a lot of neuropathic problem also. So cold pack, and not directly on the skin. You have to wrap it in a cotton bag or something to give some insulation and preserve the skin. Other common problem that you see on a regular basis is called as Morton's neuroma. Morton's neuroma is very common for people who wear very tight shoes, heels, or it can be some cases because of the complex structure of the feet. Some cases because of rheumatoid arthritis, the bone positioning is zigzag, and the nerve which is passing between mostly the third and the fourth metatarsals get compressed or swollen from inside. A test for that is you just take the patient feet in your hand, put your hand across it and try to squeeze the forefoot area. If there is a Morton's neuroma, there will be an increased pain in that forefoot area, and you can determine that it is the problem. In such cases, on the orthotic side, you have to add a metatarsal raise so as to lift the forefoot area, and the pressure is reduced on that. Other things is mostly gabapentin and other supplements are needed to reduce the nerve swelling from inside. They cannot wear shoes which are too tight, too flat, so they have to go for open footwear for some time, or wear a sports shoes if they can't wear the open footwear, and that will help in reducing the pressure. Proper examination is little difficult to determine these things. MRI is also inconclusive. In some cases, if you do sonography of that particular area, you might be able to find the neuroma spot over there. In certain cases where people have hallux valgus, where the great toe turns inward, it can also cause increased pressure and reduce space between second to the fourth metatarsal, and that's why the motor neuroma happens. So we can try to work on in a way that we are having a medial arch support which is trying to offload the hallux valgus also, and we can do the hallux mobilization and training so as the pressure on the other toes are rest. Again, we can't push them further inside by tight shoes, so that's why we have to shift to a more roomy manufactured wide shoes. Extra wide shoes are also available that helps in reducing such issues. Now, tough toes, capsulitis and all those things, it happens due to rheumatic trauma. It can be there in athletes most often. So certain sports, they are running, they are jogging, people who are into ballet dancing and all those things, they are too much onto their great toe, and all those things causes inflammation of the capsule, ultimately leading to the discomfort, pain and laxity around the knee joint, again around the foot joint. So for them, we need to give orthotic insole. So bunions are usually well responsive to orthotic treatment, but it is not responsive to that toe separators and other stuff that is being popularized and used. If you see the X-ray of a bunion affected patient, you will see there is increased gap over here. That's why the toe is coming over here. Now, if you put a toe separator in between over this area, it is not changing anything around this area. So the bone will still be putting load onto the other side, and it sometimes worsen the issue over here, and there is no pressure. Now we need the pressure on the great toe to come in a proper way so as to adopt in the gait cycle. So if we have a toe separator while walking and our effort is there to hold the toe separator, the bunion problem is not at all resolving, I can give you guarantee, but you are losing your mobility at the forefoot area to do the proper toe off. So that is why I won't prefer active use of bunion, but sometimes bunion splints can be used as a night splint. Try to separate it to ease off the pressure, do a lot of mobilization, and basically the correction is done behind the bunion, not on the bunion or in front of the bunion. So you put a arch support, you can put a metatarsal raise, and you can offload the pressure on the bunion. But if you do on the spot or away from it, it makes no sense to treat it. Then we talk about the shin splint, or the pain that you feel in the middle of the foot, in the front of the foot. It mostly happened as a overuse injury, where we have long distance runner, marathon runners, ultra runners, these days Ironman running. So they do a lot of running and walking and jogging on a hard surface, and if they don't have a good supporting shoes, or a shoe which is giving them rocker bottom effect with a shock absorption, they end up having a lot of tension build up in the anterior compartment of the tibia, and there's the shin splint start happening. We have to release the calf and the hamstring in this case, because if the posterior pressure is too high and anteriorly the dorsiflexors were weakened, then this pain will start having more trouble. So while you do strengthening of the dorsiflexor, uh, so reverse heel raises you have to do. You have to do toe raises with little resistance with the help of a TheraBand or a weight. And then what you try to do is to release the calf. If there is excessive development of calf and tight calf, then the front part has to suffer for it. In runners, you have seen that, because they have very, very strong, very restricted, sometimes they are very lean mass also. So the posterior structure is small, tight, and not well lubricated. जब मसल में आपका फैट नहीं है, आर्टरी ब्लड सर्कुलेशन अच्छा नहीं है, मसल की गर्द अच्छी नहीं है, at that time the blood flow can also be restricted or smaller than what you require. So people who are long distance runner has to take care of their calf strengthening on a regular basis. For them, the training is better if they do uphill running. Agar for the time being, when they are suffering with the shin pain, they don't want to stop activity, they want to continue running. So you can ask them to do training on a treadmill for some time, but with elevation on. So if they do that, the shin splint will bother them less. Uphill running will bother them less. They can do swimming and cycling for the time being, so that they can sustain the flexibility and range of motion and the strength around the muscle without getting completely into chronic pain. So that kind of modification of exercise protocol is needed when you are treating such problem. Now comes the bunion or the hallux valgus specifically. So see this X-ray, you can see the cavitation happening, or the increased space is there between the first and the second toe, and it is more about the change in the bone angle. Usually, the best treatment and the permanent treatment, sadly, is with surgery only. You have to chop off the extra bone that has protruded out, reposition the bone inside, and then put a screw and get the leg straight. Sometimes wiring and other techniques are also done, but it's a very complex surgery where the chances are very limited and the risks are little higher. So most of the people won't adopt in India because of lack of proper surgeons and lack of need to cosmetically correct it. Not many surgeries are done. I have seen, I think, 1 or 2 patients only with bunion surgery in my 10-11 years. So that rare the surgery is there. Now, why I don't try to advocate the surgery in this cases, because I want to retain that flexibility at the first toe rather than making it restrict. Now, another thing that you will see with patient who are having bunion, they might have good or normal arch. A slightly lower arch can be there in a very obese patient, but in thin patient also with severe bunion, you will see the arches are more or less okay. The transfer arch is the only one which is dropped down, which we can easily taken care of. But still, even though they don't have flat foot and other thing, we will still give them a orthotic support that supports the medial arch. And once we support the medial arch, the great toe is much free and it stop further deteriorating. So sometimes the treatment is not to get back to normal, but to stop getting it worsen also. So then again, this scope of treatment should be explained to the patient before we try and give anything to them. So those are more of soft tissue related issues. Bunion is more of a bony and structural problem. Now, the three most important thing which we see is pes planus or the flat foot. There are different representation of this foot. If you see the one in the extreme right hand side corner, the old man, see the deviation of the forefoot, see the rotation around the medial tibial side, and see how the naviculum is changing the position and dropping to the ground. There is no gap between the arches, and the angulation on the lower end also is wrong. So this kind of a case is almost severely overpronated, and if we try to do foot posture index in this case, it will come to plus 12. So it is like an absolute flat foot that you can see. And if you see the middle picture, at this point you can see there is some arch underneath. So this is somebody who will come between 6 to 8 on the plus score, and will be doing well with the insole and orthotic. So good place to be. If you see the skin condition, there are some blue veins which are available. So we have to see in such cases whether they have diabetes and any other correlated problem, varicose veins and all, and then we can start the orthotic treatment. If you see the first picture, it's of a kid standing with overpronation. If you see, the right side is not as everted as the left side. So he has bilateral flat foot, but the left is deviating more than the right one. So we need different customization. One shoe that is available in the market cannot solve or differentiate between these two. So again, customized insoles are the solution. These are different ways of hind foot misalignment. You will see how much the Achilles tendon start popping, and there is a swelling around the medial column that you can see. In this thing, in the foot posture index, what we were talking about, the superior and the inferior lining, you can see how it is being curved around this area. So you can see more than 3 toes again in this picture. So this is more or less going towards the maximum, plus 12 scoring on the overpronation side. Okay, this is slightly lesser than that one, so it might the next two might go to 10 and 8, but the first one is definite 12. This is how the cavus foot look like. In this thing, the medial malleolus is pushed inside. There's not much of a gap over here. The tibionavicular joint is slightly positioned upward. The forefoot joint, like the metatarsal joint, they are very stiff. You can see this as the instep area, which is rigid and high. So instep is very high. ऐसा लगता है जैसे ankle is on first floor and the toes are there on the ground floor. So that kind of a deviation and the difference is there between the forefoot and the toe area. So this causes more rotation towards the outside. It is a poor adopter. So medial side of the joint will not come down. If we get a chance to understand that functional foot nomenclature, you'll understand this foot type. In this foot type, if you see the forefoot area, the first ray area is already showing a red and a little swelling kind of a thing. If you see the nail condition of this patient, there are linings over there. The skin is very brittle and dry. On the nail side, it is very brittle and dry. You can see linings also. So there's definitely some blood circulation issues which we are seeing in these cases. Many a time when you see a diabetic patient, what you see is there's no hair, like this feet, there is no hair on the toes, there is no hair on the midfoot area and little above also. So if the hair loss is there in these particular zone and the skin is glossy, too much deprived, little reddish, too much fluid inside, then there is a strong chance that this person is having neurological involvement and diabetic or non-diabetic neuropathy. The other common injury that we see are the lateral ankle sprain or the eversion injury. Very common in football player. Few players in I have seen in tennis, in badminton also having this eversion injury, and I have seen way too many cases of female who were just walking, maybe a platform, maybe a heel, maybe a flat foot, getting this sprain. So involuntary sprain just on normal walking is very common, where you are not playing or doing anything but your ankle twisted. And micro trauma is very common. They keep on having stability issue and they keep on going onto the outer side, getting strained and then coming back. So that is where these injuries happen. We call this injury as a eversion injury while you're standing and walking. So to summarize, we have 2-3 foot type. We have a supinated foot type, we have a neutral foot type, and we have a pronated foot type. Now, as per these foot type, we have shoe types also. Everything is not for everybody. So for people who have a high arch, as we have determined that their shock absorption and their adaptability towards surface is poor, we need a shoes that can provide them balance and dynamic activity. Maybe they should be stable. So stability and balance is something that we are looking for. These kind of shoes are more of cushion shoes because we want the shock absorption part also to be taken care of. Typically, one of the best shoes that I feel that is there for supinator is in the brand ASICS Gel Nimbus. So that particular shoes has a good control on the heel counter, and while you're standing and walking, the pressure on the lateral aspect is less. Shoes which are little rocker bottom, slightly raised, are also good shoes for this foot type, but they need a thicker bottom. They should not go for low stack height or very thin shoes like canvas shoes, Converse shoes, flat chappals. They are not good for this foot type. So they should wear, like if they are female and they are wearing open footwear, then they can go for platforms, something like fit flops and all those things in common usage is good, but they can't wear kolhapuri style flat chappals. Mostly they will have calluses and heel pain much faster than other shoe type. In neutral shoes, we are comfortable with shoes which provide a good heel counter. We need enough space to wiggle the toe inside the shoes. For me, if you're doing running, jogging, walking, or any kind of a sports activity, always opt for lace shoes. You should be having good grip, like when you're wearing a shoes, open up the laces and make it loose, and then you put or slide your feet inside. And once you remove it, open the laces and then slide it out. Uh, Around 85% of my patients will never do this. So they come and then they just throw away the shoes. So that is where I know that this is a big problem. If you don't take care of that, you have more trouble. So always insist to your patient and not patient to, at least for you, whenever you are buying a good pair of shoes, you are paying for its heel counter and the stability. Open up the laces, put your feet inside and then tie the knot. If it is gripped well, then there will not be any play when you are standing and walking. Your foot will not be allowed to do pronation, supination, or go forward and backward. Once you have a shoe, they say there are many people who are having a broad foot and they wear 1 or 2 size bigger. So then there is increased gap in the front, and while you're standing and walking, your feet keep on doing this thing. So there is increased friction in the forefoot area, and there is unnecessary elongation of the feet that happens because you're wearing a size bigger shoes. So try to find the shoes not only as per length but as per width. Now few brands are already there in India which has started doing. We used to have brands from US, we used to import it as per our patient's requirement, but now it is getting a little easier to have these things at RXs in India as well. Then for the third foot type, complete flat foot, overpronated feet, where the foot goes inside. Again, the wall of the shoes from the side is very important. It should be gripping, it should be hard and rigid, and the heel counter, which is the back of the shoe, should be firm and rigid and not allowing the extra eversion that the flat-footed people do. So these kind of a support are called as support or control issues. In brands like Asics, there are model like GT 2000, 3000, Keanu that helps in supporting the middle arch and other thing better. There is a brand called as Brooks in India, which makes manufactured wide shoes. So that can also be an option. If we are doing insoles and orthotic, what we do is we choose shoes like Hush Puppy, Clarks for formals, and we take out their sole and then we put our sole. Then the shoes is never tight. Now, I think. So now the other problem that.
Excuse me, ma'am.
Yeah.
Excuse me, ma'am. Yeah,
Yeah.
I'll just request participants on your behalf that if they have question, they can put in the chat box.
Yeah.
So that
Yeah.
you can answer when you finish your particular
Yeah,
task.
this section is going to end soon. So if there are questions in this section, just put it on the chat.
Yes. So another 15 minutes, participants, whoever is watching, whatever is question with you, kindly put it on so that we can know if there are repeated questions. Madam will answer in a single go only.
Yeah.
Thank you so much, ma'am. Sorry. Go ahead.
No problem. So when we are talking about leg length discrepancy, as we have discussed earlier, if you don't put equal weight on both the side and the body and pelvis shift to one side, there is increased loading causing pressure not only at the feet but the knee, hip, spine, scoliosis, kyphosis, all other problem happen. So it is very essential to measure the length of the feet, and the right way of doing it is we do a test called as a scanogram lower extremity. In a single x-ray, we see the length of the feet from your hip towards your heel, and there is a segmental length of like first half till knee, what is the length, second half from knee to the ankle, what is the length, and what is the total length. If there is a huge difference, we try to cover it. So I have seen LLD till 9 centimeter. So this much big block has to be done to compensate. It was a traumatic case. I have seen cases like polio where we have to do this thing. Avian, we do partial correction, we don't do full correction. Single-sided knee replacement surgery you'll always find. Some people have chronic back pain with little or no problem at the foot alignment, and we got the scanogram done because we were not liking the posture that they have, and the shortening was say 4 or 6 mm. We corrected that, and then the pain was reduced. So usually recommendation is not to do anything for a leg length discrepancy lesser than 4 millimeter. You start doing it above that, but 4 to 4 mm to 90 mm I have tried to compensate it. Now again, we have discussed this earlier that if you have a pronation or a supination issue, the direct impact is onto the pelvis. It will be in either in the anterior pelvic tilt or the posterior pelvic tilt. SI syndrome is very common in them. So try to correct the foot and you will find the result in the pelvic and the SI segment of the body. For the knee issue, if your foot is pronated, your tibia is internally rotated, the knee joint, which is supposed to be sitting on top of each other, and there are grooves that are passing and causing the smooth flow, is getting disturbed. So either it can pass forward, backward, or sideways. It is not congruent. The bone will come in contact with the bone, and there will be huge tightness of the IT band. So the IT band will start pushing the knee inside, which will cause medial knee pain, which will cause arthritis, uh, pre-patellar, post-patellar pain, and chondromalacia patella. So all this problem can be easily resolved with the insole and orthotic. At the knee level, you have to do mobilization, try to create as much gap as possible. Cartilage supplements and all those things are important along with the anti-inflammatory. So you have to work with the medical side of the thing with the orthopedician, but mostly the solution is there in orthotic insoles and correction rather than the medicines. So most of the time, why we fail these cases of foot problem is we try to address the tip of the problem. We try to see what our eyes can see, and we don't go too deep to understand what is there. I have helped people identify cancer because I did my examination right. So many a time there are so many underlying issues. Psoriatic arthritis are there. There are many cases people are just going and they think that, okay, it's a pain, it's a pain. They keep on going to the orthopedic doctor who is not even removing the shoes of the patient and examining. Sometimes x-rays are not taken and there is a charcot foot that is developing. The person is just going, and then there are some ulcers, sores, or some pus which is developing under the feet and it was not examined. But if you follow few things, start seeing the MSK cases first, then you move towards the sports cases, and then you go towards the diabetic case, it will be much easier. It will come to you. The principle don't change, but your observation power keep on increasing. With more cases you check, and you can then identify something which not many people can see in cases. A little bit about the diabetic foot. A short story why I'm so passionate about doing this thing and why podiatry is so important for me, and I try to do my bit in terms of learning new things and teaching new things with diabetic foot or foot per se, is the fact that my mom, she got 2-time amputation done. She was a diabetic patient. There was nothing wrong as such. There was not a major issue, maybe due to little ingrown toenail. There was a small wound and the doctor was too hasty to do the treatment, though she started treatment at the right stage. At the early stages she was going to the doctor, but 10 to 15 years back, the wound healing side was not that strong with the doctors, so they used to use a lot of betanin to clean the diabetic wound and all. It causes more bacterial growth and all those things rather than helping, because the moist wound is difficult to heal. So a lot of problem used to happen, and ultimately what he observed and said that the skin infection is not getting control, and it is going, the pus is going towards the bone. If it mixes the bone, it will go through the whole system, and it is a life threatening problem. It can cause her necrosis, and we have to amputate the whole feet. So it's better, let's amputate her toe. At that time I was the decision maker. My father was posted in different city, and I was the one who signed up a document to say that cut my mother's toe. And that is something that's an unpleasant memory that will always remain in my life to remember, that though we do so many things in our life, our parents give us a good body, and I took something of her. So the fault was not mine. The fault was not even hers. Diabetes is such a disease that it changes its face like anything. So it's a chameleon. You can't do much about it. Even the doctor at that point, with the limited knowledge that they have, did what they could do best. But what happens, like when the surgical part ends, the doctor don't observe your biomechanics. They don't know what the biomechanics is, how the body move, what the movement are caused. So they don't advise proper footwears and all those things. They depend highly on orthotist to design those things, and they have a limited understanding about biomechanics. They look at the feet, and what they see, they try to just make a hole for diabetic ulcer. They try to offload the pressure, and they think they have done what is needed. But it is just the internal part that is missing, which is the bigger problem. If you people now have understand a little about biomechanics and gravity and the axis and the plane. So imagine a diabetic wound ulcer at this point, which is happening due to a flat foot and a collapse arches, a collapse transfer arch, and there is tightness at the back of the heel and everything. This person cannot have a good ground clearance. Now he has a wound and the doctor is doing the wound dressing, wound treatment, best of the thing and everything. They are doing dermagraft and all those things. And once it is done, they are dependent on an orthotist who makes a hole in the chappal. They ask a soft chappal, or they make a sandal or a chappal, and they make a big hole here. Now further the body is going inward only. Okay, it is giving more space for the bone to collapse down rather than lifting it up. So the term that is used for foot orthotics is called as offloading devices. Now where you have offloaded, you have just accommodated what was wrong. And similar thing with the soft chappals and all those things, they keep on pressing it down, they keep on pressing it down, and sometimes if this side is the wound, they are using more of the other side. So this side started causing more trouble to this side also. And the contralateral side knee is always affected. If you have a wound or an injury on one side, the contralateral knee will always show arthritic change. Purani ligament injury, which was treated or conservatively treated, no pain now, will show pain and discomfort or deformity on the contralateral side. So the various risk factor for diabetic foot is peripheral neuropathy. They have loss of protective sense, and then they have peripheral arterial diseases. All three triad, along with uncontrolled diabetes, obesity, lack of movement, lack of muscle strengthening, poor core strength, are the leading causes of diabetic foot ulcers and problem. So as per the functional foot type, I have not taken too much deep into the functional foot type because it's a complex thing to understand and much easier to understand when we have in-person kind of gathering. Here, say if somebody is having a high arch or a rigid forefoot and hindfoot kind of a thing, they will have wounds more in the metatarsal area or the lateral aspect of the foot, because biomechanically they work with the supination. So supinators will have typical of those things. If somebody is having a lot of rigidity at the heel area, but the forefoot is free, then they will have it in the middle of the foot. So like we were talking about pronators who are having flat transfer arch, because transfer arch was not holding, it is on the ground. So forefoot ulceration and all those things happen. If there is too much of a flexibility, then the whole feet collapse. The lateral aspect of the feet can have some problem, because fifth and the first two both are taking lows, the bunion will be there, so lateral side of the calluses and all will be showing it. And stable is the front and the back can do this thing. So that can happen more of the traumatic thing, like a nail poking you, or there was some stone inside your shoes, that can also lead to that ulceration. So normal foot type can get ulceration due to those conditions also. A flat and flat foot type are usually having claw toe, hammer toe, and other foot deformities. So they will have under those areas and under these things. They have very shallow grip, and they are mostly people with low fat pad also. If you have too much of a flat foot, the fat pad is low, so shock absorption is less. So these are the correlation of a proper foot type to these things. And we can see where the pressure zones are. If we do early screening, we can stop some calluses and other ulcers to develop in these cases. So regular foot pressure mapping should be done in these cases to help avoid ulceration to particular part. For diabetic foot offloading, orthotic alone sometimes is not a option. So there are different kind of cast and shoes that are used, air cast. This one what you're seeing is a Vaco Paso. So basically, if you see the beads around this area, this work on reverse vacuum. So once you put your feet inside, they try to release the air out. So then it creates that vacuum inside, and then it helps. Certain Vacopaso and all, there are another variety in which they insert the air to create the vacuum, and sometimes they suck the air to create the vacuum. So it works into plaster cast kind of offloading, which is very much required in charpot foot. So it cannot move much. Then there are a simpler version of these things. If you see the feet, there is an insole that goes inside in the shoes on the right side. In this insole, there are beads like Raika Dana Hoda, Vesa, it's there, mustard seed. So that kind of seeds are there inside in this pouch, and underneath there is a black foam that is added. If you want to offload the pressure at cuboid, say in this area, then the second from the behind, you can just remove the foam under that area, and it will offload the pressure and load onto the cuboid, and the lateral arch pressure will be reduced. In the front also, you can deduct some pressure. If you want to offload the pressure at the toe behind section, you will make the bone sink so that this section will go up. So hallux rigidus and limitus ka concept agar aapko malum rahega and you will examine that thing, you will be able to offload. In certain difficult cases where there is already an amputation and all those things done, then different kind of foot insole customization has to done. So this one, if you see a half kind of a thing, it is for transmetatarsal amputation. So the whole forefoot has been cut. If the person is wearing same size of shoes and there is a missing part here, it can cause re-ulceration in the front foot area. So in diabetes, first thing is, if you can see the top, it's a pink foam is there, that is called as plastazode. Okay, so this is transmetatarsal. The whole stump will come here and it will support the feet. In this, it's a first digit metatarsal amputation. So there will be a lateral flare and rest of the portion will be free to stand. So it will help in contouring, and there will not be a pressure from the shoes because the foot is not allowed to adduct when you are standing and walking. So both abduction and adduction of an amputee has to be controlled inside the shoes if some part is lacking or missing. So always believe in understanding the root cause of the problem, and then based on that you can decide which line of treatment you are going. If you are strong at your physiotherapy, if you are strong at your neurophysiotherapy in terms of balance training and all those things, you can utilize all your time and effort in that direction. It is possible that you will get the required result and you don't have to look into other things. But if foot alignment, specifically bone alignment, is coming in action, trust me, all your effort will be giving you half result or no result if you don't correct that thing. You have to start the correction from bottom up. That is how the examination and the treatment of most of the people, because we are a moving being, we are a mobility driven individual. So we need to understand the mobility first and then solve all other problems in the body. So various people, various school of thought, they can say that I can treat heel pain by cupping, needling, hijama. We can do only arch support, we can do braces, we can do sleeves kind of a thing like compression bands and thing. Some people believe that through rigid tape or kinesio tape also we can help these things. Then injections, corticosteroids, then anti-inflammatory medicine. Nowadays PRP is used, physiotherapists are doing things, splints are being made, taping techniques are done. So there are various things. It works for some, it won't work for others. So you have to understand what works for whom and why, and what is not working for them. Don't be blinded by your treatment protocol that only this thing. I have recently done a course on acupressure, so I will do acupressure, acupuncture, dry needling on everybody. Then whatever cases you're seeing, you're not seeing whether it is diabetic, non-diabetic, what else is happening, and then your decision making is clouded. So never get into one. Don't get comfortable with one modality that worked for one patient. Like ultrasound is absolute. There is zero to no effect of doing ultrasound. Okay, but if you want, you can still continue doing that for the psychological benefit of the patient, along with Volany and something. So at least superficially, the inflammation can be taken care of. But internally, if the bones are not corrected, the effect will not be there. So it cannot solve. So try to give as much right advice you can, and then you try to see what you can do. When we come to the orthotic side of treatment, there are various company, there are various option available. So today, for the sake of knowledge, I'm using my own product that we use on a regular basis. But there are various other product available in the market. But what you have to understand, there is a difference between an insert and an insole and a customized orthotic insole. So when you go to Bata and you buy that Scholz ka patla sa gel wala thing, which is flat or might have a metatarsal raise up, those are all inserts. You see a lot of ad these days on Instagram and all those things for a company called as Frido. So what they do is they have a gel and then a cotton top on it. Now imagine a person who is fat enough having a good fat pad. What benefit another fat pad under the feet will do? It gives extra cushion and shock absorption, and to what extent it can change the biomechanics. So there the advantage are very limited or none if you don't change the biomechanics. So you don't call it as a insole if it is not helping in changing the bone alignment or the soft tissue repositioning in a way where the pressure is offloaded. So orthotic insole has to provide corrections in terms of alignment and stability. Then if you just see the pectoral thing, there are half sole, there are 3/4, there are full sole, there are heel cups, there are soft shock absorber, they are hardened soles also. So there are multiple variety. Choose what is best for your patient depending on the kind of footwear they wear and depending on the physical activity that they have on a regular basis. Okay. AFOs and all those things are also used, but they are not part of podiatry orthotics. They are mostly done by orthotists and they do the better job. Foot drop splints and all those things are more of a expertise of an orthotist to take their help to get that thing. When we are coming to the orthotic design, there are different theories that I have not taught you today to develop the orthotics as such, but the most important one is tissue stress theory that is there. Earlier, the subtalar neutral theories were the most driven force to design an orthotic. In subtalar neutral theory, what they believe is if the subtalar joint, while we are palpating, is in neutral, like we can feel it equal on the medial and the lateral aspect, then the body is stabilized. So all orthotic were designed to the level that the subtalar comes to the neutral. Now what they believe is while we are trying to do so, we have to make sure that the stress that comes on different tissue where the forefoot pressure, hind foot pressure, the frictional forces and everything has to be taken into consideration while you're customizing the insole and designing the orthotic. So that part has to be taken care of in the orthotic design. So we can have as I said, that some people can have functional flat foot, some people can have a structural flat foot. So if they have a functional flat foot, it means like the muscles and the ligaments and the tendon and the bones are not positioning themselves well while you're moving. but overall on a non-weight bearing position, their structure and functions are intact. So that kind of insole, we try to give orthotic which corrects them. For over flexibility, for flat foot with kids and all, we try to give them more of the insole and orthotic that can help them in regaining the activity back again. For people who have absolute flat foot, complete flat foot, there's no mobility, there is hallux digitals, limiters, and all other problem together, and we try to give an insole. We are trying to accommodate their deformity. We are not trying to change their alignment. जो है उसी को maintain करने की कोशिश करेंगे. So in that cases, we are very clear with the patient that आपको further callus, corn, ulcer, dry skin वगैरह ना हो, इसके लिए हम लोग insole दे रहे हैं. In previous way, there are different ways of doing the insole measurement and formation. The very first thing, the white one that you're seeing, it's called as POP cast. So first there is a negative cast which is taken from the patient's feet. Then it is being filled or scanned, and then based on that, the positive cast or the insole was created. Then again, it was very tedious, time taking, and a lot of mess around to do the POP, wait for it to get dry, then remove it, and then take the casting off. So it was very, very difficult. So then they come up with a foam box kind of a thing. So you take two foam box, it has a right and a left side. You make the patient put their feet in a neutral position on it. You try to keep the subtalar joint in neutral while you're holding, and you then ask the patient to stand with full weight on that. And while you do so, their feet goes inside the foam, and it takes the countering and the surface of the foam, which is then used, like we used to put like some liquid inside to make a cast, and then the insoles were created. Nowadays, we can do pressure plate analysis, we can gather the data, we can gather the graphic, and then we do a printed insole from there. We can do a foam printed insole, or we can do a 3D printed insole on a TPU surface. It's kind of a plastic surface. So, and this is one type of foam. This thing, it comes in a square block. The video that is being captured on the plate is transferred to a software. On the software, we can take a call of how much arch we want, what is the depth we want, what is the contouring we want from behind. And once we done all those things, we see what density of the foam that we need to do. Do we need to have two density front and back? Do we need to have two softer density for diabetic, and for geriatric patient we'll go for a softer density. We make all those things, and then with a grinder we can give a fine shape. So the machine in the box cut it, make the insole, and then fine grinding and everything is done, so there is no rough surfaces and all. And then in the last, a top cover is pasted on top of these foamy insoles. So you can see this is a multi-layer insole. There is a black foam which is giving the rigidity from bottom. There is a blue foam which is for cushioning and shock absorption, but it is a medium density. It's not too soft, not too hard. And then there is a top cover of 1 mm on top of it. So this will be the final thickness and insole, which can go inside sport shoes easily. If they don't have a sport shoes, then they have to buy a formal shoes which has a removable sole, then it can go into that also. Same method, same capturing and everything, but then the final insole is made on a TPU. So on the software, it does the printing. On the 3D printed, the whole insole comes up. And then what we need to do is we just have to add a top cover on it to provide you stability. So few companies in India and abroad are moving towards 3D printed because lesser logistics are required. So this is how the 3D printing insole work. EVA, TPU, or polypropylene. So it's like a carbon fiber kind of insole. Once you make it, it lasts for life. So for people who have fixed deformity, their alignment and all is not gonna change, and they want to use it. Mostly it is done in 3/4 the carbon fiber. It's very expensive, say around off the shelf version of it is say about $650. off the shelf. Customize is more expensive in that, but they last good. And most of the company which give this kind of insole keep the data, because the foot alignment is not going to change, and they can reprint if need be. So that is how it works. Usual life of 3D printed TPU kind of insole is 2 to 3 years. Foam insole, depending on the density and usage, is about 2 to 3 years. Logically, we tell the patient to change these kind of insole, which is not carbon fiber, every 2 years for hygiene and shock absorption purpose. Otherwise, they become very rigid, and they don't give the proper support to them. Then one more variety is custom molded insole. You can take an insole which is too flat. I have a machine for that. Then we heat up the insole, you make it stand on top of it, and the insole get wedged between. These are very good when we are looking for a total contact orthotic, where we want to do proper arch correction along with a good grip and support. So most of the sports individual, we use these kind of insole. We have done it for Shubman Gill as well. So he used the sports version of similar insole that gives him the stability to stand and take his shot much better. So that kind of a thing, we have done it for national and international level rifle shooter as well, for various squash, table tennis, and all other individual. We even made this kind of insole for Shah Rukh Khan as well. So this is like very commonly used, but it is not useful for people who have absolute flat foot. Too flatter footwear, it won't work. So for them, we use prefabricated custom molded insole. This is a typical prefabricated custom molded insole that we import from Australia. It's been designed by podiatrist over there. It has some basic design. There's a deep heel contour over there to give the grip to the calcaneum. We have 4-degree arch correction profile in this. All the hygiene and all other things are there to be taken care of in these things. The advantage with them, if you see the bottom part of it, there is for shock absorption, because we base our yeah, sorry, I think I was disconnected. So in this, we can cut and trim and put it. We don't need a grinder or much of the thing, but on a OPD basis, you can easily use these kind of insole for customization. It can go from one shoes to another. Usual life is for 2 years. Second thing, it comes with a heating zone. So for minor adjustment, we can take a heat gun and heat it up, put it inside the shoes, then hold the patient feet into subtalar neutral position and make them stand on it. It will help and give them the support over the right area. Then what we have is a solution for different kind of shoes. So not everything fits in shoes of all type. So we have full length, then we get the quarter length of the same thing. Technically the support and all those things is same, the correction is same, but it don't have the front part. So it is easy to go into a taper shoes or a little narrower shoes, or in gents, when they buy different brand of shoes, the shoes are slightly different in sizes in the front area. So for them it is just 3/4. It won't make the forefoot area too tight, and you can still wear the existing shoes. If you buy a new pair of shoes, at that time you start using the full length, and buy the shoes accordingly, that you can put it in a formal shoes as well. Like Hush Puppy and Clarks have those options. Then for females who have whoever trouble and they have to wear heels and platforms and all those things, then they can use something like this. It comes with a Velcro. I can't provide any further correction in this, but on a heel or a stilettos, they can just put it on top of it, and it will help in offloading the pressure from the forefoot and the rear foot area, so they can stand better during the day. So it reduces the muscle soreness and tiredness that comes with these things. For housewives and female who are mostly in homebound thing, we have the sleeper option as well. It has the same technical specification of an insole, no further customization, but 99% of the time for calcaneum pain, heel pain, foot pain, Achilles tendonitis, this has helped people solving the problem. If you see from the footwear design also, it's little complex. It is curved in the midfoot area as well. So it contoured around to the body, and it can be used easily by old age people also who are not very comfortable with closed shoes and sports shoes all the time. And if you see the Indian this thing, we can't wear shoes too much. Females are not much of a habit of wearing sports shoes anyways, so for them these kind of a thing is a good option. When we talk about the application of these things, it can help solving most of the foot related problem. Any of these insole with different combination of wedges, we can help solve from heel pain, foot pain, Achilles tendonitis, spurs, bunions, metatarsalgia, turf toe, overpronation, underpronation, claw, hammer toe, and all those things. We can solve that thing. I'll show you what wedges will help doing so. When we are doing all this insole, it is very important to choose the right fit of the shoes, length, width, proper grip and support. The posterior part has to be taken care of. So now it comes to the wedging part of the things. So first we choose the right size of the insole. It comes in different density also. For patient who have weight 80 kg and below, we use something different. For 80 kg and above, same comes with in a hardened density. So these are anyways, the basic one is also not foam or soft material. It's PU and PVC combination. So it's a very firm and rigid material. It gives that anti gravity support that we require. We really need to push the bone away from the gravity. That is one point that somebody asked about navicular repositioning. So we have to support the naviculum with the help of insole to reposition it. Otherwise, with exercises, taping or anything, it cannot be repositioned. So first we check the insole part of it. Then we see even after standing on it, how much the foot is pronating. If it is still pronating, it has 2° and 4° rear foot wedges. So it comes with a sticker and glue. We put these in this part, and if you see the design of it, when we add it, this mix with the contour of the arch, and gradually it raises the arch angle over here. It is tapered on one side and raised on one side by 2° or 4°. So whatever 4° we already have, we have added more, 2 or 6° plus also we can add. Beyond that, the foot is little difficult to correct also. We can put one, we can put two of these to increase it to 6°. So we can keep on adding these things. Now, supposingly, if somebody comes with a posterior heel pain, the arch alignment was okay, there's no pronation, supination component to it, but only the posterior heel pain is happening, then we will add a bilateral heel raise, or if there is a LLD, we'll do the heel raise on the side that is shortened. So we have wedges like these which can go inside the shoes. There's a limitation of correction that you can do inside the shoes. So in this kind of a wedges, the back portion is raised or high, we put it like this, and the front portion is tapered. So you will get a slanting support. It is not like immediately going on a heel. So it slants the weight down and increase by 5 mm, 10 mm. We can add 1 or 2, but after that the shoe insole will start coming off. So say somebody is having 2, 3, 4, I see 9 centimeters, then we have to add something on the shoe side. So we take the help of a orthotist or somebody, and we get the height raise pasted onto the shoes from outside. Then for somebody who is having forefoot ulcers, forefoot pain, metatarsalgia, Morton's neuroma, hammer toe, claw toe, and all those things. So first we will do the hind foot correction, and then we see how the forefoot pressure is offloaded or not. If we are not happy with the forefoot correction, this is where the transfer arch mostly sit. So just behind the transfer arch, we will put a metatarsal dome. So once they stand on it, it is a soft and cushiony thing. It will offload the pressure in front of it. The calluses will start decreasing. The skin will become more softer. And if there is a small corn or something on its own, it can just dry out and fall off. If need be, they can do 1 or 2 pedicure also. That will not harm them. Sometimes we want to give them shock absorption. They are having posterior heel pain or so, then there is a poron support. It's just 1 mm, we just add it at the back of the heel. It gives that extra shock absorption. Sometimes people feel it more on the skin, so we sometimes do a modification and add it in the top portion also, but mostly it is meant to be done at the bottom of it for extra shock absorption. Then for people who are supinator, sometimes there are people who are excessive pronator with abduction. So in that we will do the rear foot and the valgus correction both. And in certain cases there is pure supination, so we will do only the outer valgus correction. So this is something to support the lateral wall. In cases of cuboid syndrome, in cases of fifth toe pain, callus, corn, ulcers, in case of calcaneum over inversion, then we will do all this thing. Sometimes we can't go by the book and do the same thing. There is a lot of calcaneum deviation that is happening. So what we do is we always keep the extra wedges with us. We cut this to half and then add half of it over the insole. So it will help in tilting the body from bottom to the center also. So once you do the normal thing, you can do your little experimentation within the limit of safety to your patient. Some more modification, permutation, combination you can done. So these are like least investment things. You can have few insoles and few chappals and start learning from it. And once you get the neck of it, you can invest in softwares, you can invest in machines which help in proper and full customization of the orthotic. So these are all orthotic placements and everything, cutting and trimming you do, and you can put inside the shoes. It is very important to know what is the basic foot structure also, and choose your footwear accordingly. If you have a regular shoe, like regular foot type, which is mostly the slope type, the first toe is big and the fifth toe is smaller. The shoe type has to be designed by that, where the great toe is allowed to have enough space than the other toes, but you don't want too much space for the other toes as well. Mountain kind of a foot will have different shoes, broad shoes. Broad feet with expansion in the forefoot area will require that kind of a shoes, and square shoes will require more of these things. But mostly we don't see the foot type, and we just buy the shoes that is good looking and design and everything. Just on a court side, if we can develop a 6-pack on our feet, we would have been doing more exercises and taking more seriously about the foot exercises. Hard for me to demonstrate the exercises of the feet sitting with my face onto the camera. But mostly what you try to do is you try to do a lot of toe extension exercises. Like when you're make them in sitting position, ask them to do splaying. In splaying, what you do is same as Villas mechanism. The bottom of the great toe will be on the ground, and you try to expand all the toes apart, come in between, then you squeeze down. You can do towel curling exercises. You can do alternate toe and great toe and toes flexion extension. So if you're say sitting in the ground, try to raise the great toe up, all other toe will remain down. Then you try to keep this down and take all the toes up. Looks easy on finger, but on feet it is very difficult to do so. They can do again work on the knee and the calf and other muscle, and then you work on the feet. You can do towel curling, try to keep a towel and try to curl it inside, and then with the toes you try to throw it out. So in and out of the towel you can do marble pick and drop. Hold a marble between first and the second toe. The heel will be on the ground like a crane. You lift it between first and second toe, and then you drop it to the far off on the other side. So this kind of action will help in giving you the mobility and complex adjustment while you're standing and walking. With the hand, what you can do is put, if this is your feet, between each toe, put all the fingers and try to mobilize the hand, try to create a space in between, but focus only on the forefoot area. Don't go too much into ankle movement. If you want to do, first do the forefoot and then you mobilize the ankle with your hand. You do gentle massage around the edges of the feet, mostly for the supinator. They need to do massage from back of the heel to the forefoot area to release the strain onto the cuboid. Once the cuboid is injured, the pain is extreme and difficult to solve. So cuboid syndrome hone se pehle bhi you can release those muscles. You can do cold fermentation after a very hectic day where you are standing a lot, walking a lot, traveling, या ऐसा कुछ भी करते, तो at the end of the day do cold water immersion for 10 minutes to 15 minutes. That helps a lot. Or you do a cold pack for 20 minutes. That will be good for you. But again, you have to see other medical contraindication of the particular patient that you're advising these things. I hope I have covered everything and of this thing. We are out of time, I guess. Don't think much of a questions are there.
Yes, Saurav.
Yeah, participants.
Yeah, I don't think.
No, there is a question that, ma'am, I think you have already answered. The question is like doctors advising for the soft sponge or soft heel. I think you have already answered that, and how the soft heel is important for most of the cases. I think you have answered this as well. There's a question. There are two questions came personally to me. Like for motor neuroma, is there anything like else we can do in the footwear modification, like a simple footwear modification?
So simple footwear modification is to go for a platform, and you can try and arrange some metatarsal raise like this. On the footwear also you can get a metatarsal raise. There are brands like Birkenstock, Vanek, even our chappals and all are used for Morton's neuroma. Ask them if they are wearing tight shoes or narrow shoes. Ask them to change to a broader shoes or a sports shoes for time being. And once the neuroma is settled, they can go back. You can do mild midfoot massage also. Mostly ultrasound is very uncomfortable in this case, so I don't think you should try that. But you can, with the hand, you can try to release the massage and everything. That toe spreading exercises, creating gap between the toes and all, will help in reducing the pressure onto the Morton's neuroma. So that can also help. But if you don't irritate it, it will, the swelling, there is a swelling of the nerve. It's like a bulb kind of a swelling which is there. So it will reduce on its own if you don't irritate it further.
Okay, there is a question like if there is a kind of gouty arthritis, I mean where the toe gives a lot of trouble. I mean the first metatarsophalangeal joint, what I believe. I think the participant want to ask that. So in that case, does the only the obviously the medications will help, and then exercises and other things, like how else we can change the footwear, or there are advised not to wear footwear. So how much it is?
Mostly the footwear goes towards the rocker bottom, less pressure onto the toe, more thickness of the shoe is important. They can go for sandals. If there is a female and not wearing a sports shoes, go for a sandal kind of a thing, which keeps the heel and calcaneum behind. trust me, insoles work wonder. The kind of insole that we do, it helps in offloading the pressure onto this thing. And these toes, which is hammered, as soon as they stand on the sleeper, the toes start spreading and standing straight. So they actually need support at the transfer arch. Once the transfer arch of the foot is supported, the toes are more free to move around. Immediate effect is there. So metatarsal raise is the best treatment for hammer and claw toe. And on the surgical side, tendectomy is done to release the tendon, make it straighten. So some people show good result in that, but in rheumatoid arthritis, that is also a limitation. The shoe should be flexible, mostly in the front, but different stages of rheumatoid arthritis and different presentation. The very rigid and gone case are really tough. Like I've seen the worst of the feet that you might not have got an experience, but then there is a limitation. We can't do everything for everybody, but 90% of the time you will be able to find a solution.
Thank you, ma'am. And in case of pediatric cases, if there is a flat foot, and then in that case the knock knees are also there, so there is a question like what kind of modification in the support we can try, or what kind of support we should be advising in flat foot with knock knees, especially in the pediatric cases.
Yeah, so in kids, it is much easier to do. Their joints are soft and supple. Their muscles are not too rigid and tight. They don't have a long muscle memory of walking in a certain manner. So if your muscle memory is not rigid, you can change the alignment. They are much easier to taught if we want them. And if it is pronation cause, then again the medial arch raise is done. Exercises of release of IT band and exercises to strengthen the quadriceps is there. Balance training, if in certain case it is a mild neurological involvement, you have to do. For people who are into toe skating and toe walking, the results are fantastic if you have a mid orthotics. And sometimes we go for say 3/4 length of orthotic in cases of insole, in cases of kids, so that the insole don't need to be replaced very frequently. So as the insoles are usually designed for 2 to 3 sizes, they can wear it for 1 or 2 years. So there's not a huge cost involved when we are giving orthotic insole.
Thank you so much for a wonderful session, ma'am. It was really interactive. So I would summarize what you're teaching. So ma'am has given a very good glimpse of advanced techniques as well. But more than advanced, today she actually made you all enlightened with her deep understanding of how the foot has to be evaluated. It's not just fancy softwares and monitors will do for you. It's something that right from the analyzing part as a human you have to do whenever you are analyzing the foot, and you are the best to choose what kind of treatment along with the support you need to be. Am I correct, ma'am? That way?
Yes. Yes.
Yeah. So thank you so much for interactive session, and I think that there are a lot of thanks and wishes, coding message for you, ma'am, in chat as well as on my personal WhatsApp. Thank you so much. Thank you, Salini.
Thank you so much. Thank you.
Thank you so much.
It was great meeting you all on Sunday. Yeah.
Yeah, thank you so much. So I will request CEO sir to process the certificate part.
Yeah.
So you need to just see the code, whoever is present in this event. After that, kindly don't send any message, any request message to any of the MRI number, because the event only, during the event only your certificate can be processed. Obviously, it is a subject to your video attendance as well. So code is, sir, kindly display FR15, and you have to send through WhatsApp to, always send through WhatsApp to 9066990059. I will personally try to copy the particular code and the instruction even in the chat box. Give me a minute. So code FR15 and send to 9066990059 through WhatsApp. One sec, I will paste the code as well in the chat box. Don't send your name or anything, just look at the code and you have to send it. Yeah, I have sent that. You just follow your chat box FR15 to 9066990059. This is the code. So once you send the code, you'll find a link. In that link, you put your name properly. Later on, no change in the name, no correction in the name will be accepted, because this is you who is going to put the proper name as well as your information and submit it. Within 72 hours, you will get it in your mailbox. It could be in the spam as well. So I'm making again it very sure that
No, within 5 minutes.
one of you.
Within 5 minutes,
yeah.
they will do this.
Yes. Sorry. Within 5 minutes, it will be there in your mailbox. Sometimes it get delayed. So, but normally 99.9% it will be in your mailbox within 5 minutes. So I have posted in the chat box also. You could see that FR15 29066990059. Anything else will not work. And after the event, we are not going to share any code, any kind of certificate. So the physical face-to-face event of the same topic is coming on 23rd July in Bangalore, and you'll be knowing more information in your relevant group about it. July 23rd. So you could know even everything, assessment, treatment, everything in the face-to-face training, where ma'am will be taking the training and you'll be knowing about it. So whole day you have to spend with us. So whoever is interested, kindly message us and you will be getting your discount part as well. So FR15 29066990059. And we'll keep bringing all the free and all the events, whichever is important for our fraternity. 9066990059. The code is FR15. I think, sir, most of the people has taken now code. I have posted in the chat box also. I'll post it again. So I extend my sincere thanks for joining, and I mean, obviously, are accepting our invitation and joining the event and making it so wonderful, ma'am. Thank you so much.
Thank you so much, Saurav. Thank you all. Bye.
Thank you so much.
Hope to see you all in physical workshop later. Thank you.
Fine. So, thank you so much. See you, sir. Yeah, we can wrap it. I think everybody has got the certificate also. Majority of them. Yeah, coming. A lot of messages. Very nice. I'll repeat the code FR15 29066990059 through WhatsApp on. Yes. See you, sir. We can.
Somebody is sending in the SMS.
No. Only on the WhatsApp. Through WhatsApp. I'm making it very clear. Only through WhatsApp, because through SMS it will not work. Yeah. Thank you so much, Rajesh, Suresh, Babu. Yeah. I think majority of them has got, sir, FR15. I have posted in the chat box as well. Thank you so much. Thanks, Preeti. Thanks, Jahid. All of this has got. Yeah. So for dry needling also, whoever wants, it's in August in Bombay. So whoever is joining from Bombay, Pune, Nagpur, or from Bangalore, or from anywhere, in fact, they can directly message for dry needling course. Our discount will be there for even that course, especially for our members. And the course is by Sir Craig Smith, renowned personality in our fraternity. Across the globe, he is teaching. So in India, he is doing this time with My Rehab Academy. And Econ is coming on July 16th. Every one of you, I think, know. Anyway, you'll be knowing about it, and you can join and enjoy the subject from various personalities across the globe. from Argentina, from Brazil, from US, from Australia, from UK, and South Africa as well. So many more personalities are joining there. So join on Econ. I think for Econ, the ticket rates are very, very less for our members. You all will get information in your group as well. Yes, sir. Majority have taken the certificate. Yes.
So we can wind up.
Yeah. All for joining. Thank you so much.